Good afternoon, everyone. So I'm Allison Hall. You've met my co-moderator, Dr. Croce. We're going to go on to introduce our panel. Today we've got Darshan Doshi here. We've got Yader Sandoval. We've got Judith Carasoni, Jay Catry, and Luis Palma. So I'd like to invite our first speaker to come up and chat about a very important topic. So when not to intervene. So that's Dr. Dan Kolansky.
Thanks, Allison. Thank you.
Dan has a really important topic because I always find it a lot harder to say no to a case than yes. And I'm sure you're going to help us understand your paradigm for dealing with that.
I think that's right. Thanks for the introduction. I agree. I'm going to go quickly here. So what you've been hearing about for the last couple of hours and what you hear about over the next 2 days is a lot of great technical information, and it is always harder not to intervene, and so I'm going to cover a little bit of that. I want to go over, let's start with the background for just a minute. So coronary interventions, we're all here to learn about those, and the background is when to intervene. So ACC, AHA, SCI has these terrific guidelines on when to intervene, and you are all becoming familiar with them, or you are familiar with them. And so these are the class 1 indications. A good example is the guidelines for acute coronary syndrome for STEMI, class 1 indications. And as you can see, if you follow the algorithm on the screen, somebody comes in with a STEMI with symptoms, ST elevation, very straightforward. We all know what to do. And similarly, if they are in shock, we know what to do. The harder question becomes when not to intervene. So we're going to talk a little bit about that. So I like to think about these 5 questions as an overview before we get to some cases. And these are going to be straightforward cases. These are not necessarily the 4th stent that requires laser and an OPN balloon. These are straightforward cases. So what should we be thinking about on intervening? Well, first question is the intervention likely to improve the patient's clinical status? Will they feel better or have an improvement in their physiologic status? If they're not, may not be a reason to do it. Second, can the patient tolerate your proposed intervention? Consider their comorbidities, their LV systolic function, their renal function. Will a right heart cath be useful? I think arguably it often is. Does the patient require temporary mechanical support to accomplish your proposed intervention? If so, think about it, plan it, get a CT scan, figure it out. Do you and your team, this is very important for the fellows that are emerging, have the technical skills to perform the intervention at the current time? Do you need to ask for help? Nothing wrong with that. You may come from a very supportive environment, 6 other attendings around, 3 rooms going, a bunch of nurses have been around. That's easy. You're by yourself, smaller hospital. Do you need to ask for help? And finally, are there guidelines that can be helpful in decision making? Okay, so I just want to highlight a couple of the guidelines. You should certainly be familiar with these, but remember that part of the guidelines now are these 2 additional factors, the patient-centered approach and the heart team approach. They have both reached class 1 status guidelines. So obviously you're going to get informed consent, but you also want to make sure the patient's on board. Do they know what they're getting into? Do they know they're going to need dual antiplatelet therapy? Do they know that there is a risk of restenosis? Patient-centered approach. Secondly, if you're really not sure if this is an appropriate intervention for you, for CABG, for other things, heart team approach. Don't hesitate to convene a heart team and have that conversation, whether you have that established, which we all should, or you have to do it on an impromptu basis. Heart team approach is important. Okay, another guideline that comes up frequently is left main coronary disease and thinking about CABG versus PCI. Don't forget that in patients with stable ischemic heart disease and significant left main stenosis, CABG is recommended to improve survival. It's a class 1 indication. Doesn't mean we're not going to show a lot of left main cases here over the next 2 days and deal with them appropriately. We are, and so percutaneous intervention is a 2A, meaning reasonable intervention in many cases. Surgical turn down, straightforward cases, et cetera, but don't forget when you run into left main disease to at least think about whether the patient should have a CABG. Okay, what about some class 3 indications? And I can't go through all of them, but here I picked out 3 just to sort of share what we should be thinking about. So, simple one, STEMI, but an occluded vessel greater than 24 hours and no longer symptomatic, not hemodynamically compromised. It's actually a class 3 indication, i.e. looks tempting, but maybe you should leave it alone. So think about that. STEMI with shock. Should certainly treat the STEMI vessel. It should support the patient, but the non-infarct vessel, give it a second thought. It's a class 3 indication, which means it could cause harm to go ahead and treat the non-infarct vessel. Now, there are cases where you may need to do this. You think it's contributing to the shock. We get that, but at least think about the fact that it may not be the right thing to do at the right time. Very similar approach with non-ST elevation ACS with shock, and you've treated the vessel, but now you've got a non-culprit vessel to deal with. Might be good to save it for a rainy day. Another guideline to think about is dual antiplatelet therapy. Everybody in the room is familiar with this, right? After PCI for acute coronary syndrome, 12 months of DAPT is recommended, 6 months for stable ischemic heart disease. And higher bleeding risk, we have ample evidence that shorter courses of DAPT are reasonable. That's terrific, but you need to ask, can the patient tolerate at least a short course of DAPT, whether it's 1 month, 3 months? That's now a 2A guideline. So point of showing you this is there are guidelines to think about for many of these cases. Okay, so let's get to some cases. It's a case-based conference. Case presentation 1, when to intervene. So recent cases, these are all recent cases from our lab in the last couple of weeks. 72-year-old man, recent angina and shortness of breath, diabetes, pertinent cardiac history. We've placed prior stents to his LAD, his circ, and his right. He now has an onset of recurrent angina and exertional shortness of breath. Non-invasive workup shows his EF has dropped 33%. His creatinine is 1.9. He's referred for cath. Here's the angiogram. 90% stenosis in the proximal LAD here. Patent stents in the right and the mid-LAD. Looks pretty straightforward, but he's got some heart failure symptoms. His EF is down, so we do a right heart cath. Manos will appreciate that. His right atrial pressure is 16. PA pressures are moderately up, mean of 34. Wedge is elevated, 27. He's not in shock. Output's 5.5, index 2.5. Do we proceed with intervention? Well, this is what I'm thinking about. Considerations. He's got new onset angina, but it's not ACS. He's got LV dysfunction. He's got CKD. He's got diabetes. He's got elevated filling pressures. You could go ahead. His output index are preserved. What about the lesion complexity? Looks pretty straightforward, but you're going to do an IVUS or an intravascular imaging. He may need plaque modification. Plaque modification, can prolong a procedure, possibly increase your contrast dose. So the conclusion in this case was optimize his hemodynamics, prior intervention, bring him back for PCI. Would everybody do that? I don't know, but I think that's probably the right thing to do. I'll point out that as part of the guidelines, they mention a lot of higher risk lesion features, all of which you're familiar with: left main, complex bifurcations, heavy calcification. If this patient's calcified and has elevated pressures, et cetera, he falls into a higher risk category. Here's the case conclusion, comes back, got the same lesion. IVUS shows a calcified plaque. We treated with IVL, and then IVUS got a DES. Excellent results, stable hemodynamics, leaves a day or so later with good hemodynamics and good renal function. Okay, next case. Should intervention be done at all? 62-year-old elevated troponins perioperatively after hepatic surgery, had a wedge resection. Pertinent cardiovascular history, he's got prior coronary disease and stents, preserved LV function. EKG shows sinus rhythm with inferior Q waves. He's not having angina. He comes to the cath lab after the weekend. What does he have? Got an occluded right coronary artery. Looks pretty straightforward to proceed with, but guidelines say he's asymptomatic. He's more than 24 hours after a right coronary occlusion. He's got collaterals from the left. Per the guidelines, class 3 indication for PCI, medical management, unless he's having ongoing symptoms, hemodynamic issues, et cetera. Okay, third case. 41-year-old woman, chest pain and a STEMI. Came to our lab. She's had a PE in the past, referred for urgent cath appropriately. Here's her electrocardiogram. You can see she's got ST elevation. It's not tombstones, but moderately elevated, more to the anterolateral leads, V3 to V6, a little bit in 1L. Chest pain's getting better on arrival to the lab. She goes right to the lab. Here's her angiogram. Right coronary was okay. You can see that she's got complex left coronary disease. So let's look at it a little bit more in more detail. Her young woman, her diagonal is out, her LAD looks stringy, minimal flow down to the distal apical LAD. This is what's the diagnosis here? Very likely. This is SCAD, right? So she's got spontaneous coronary artery dissection involving the mid to distal, sorry, it should say LAD, not left main, and diagonal. She's hemodynamically and clinically stable. Initial approach, most of us would argue medical management and supportive care. However, there is a body of literature. She's got ongoing or recurrent symptoms or hemodynamic instability. Then you consider revascularization, whether that's percutaneous or bypass. In this case, probably percutaneous, but she's stable. Actually came back to the lab the next day for another look, was getting better, and she's been managed and has done well. Some references there on SCAD. Okay, fourth case, 61-year-old man, pre-op last week for a low extremity bypass for acute limb ischemia. Pertinent history, he's a diabetic, hyperlipidemia, smoking, history of CLI in the other leg, preserved function, positive stress test, significant areas of ischemia. What do you think we're going to find? Triple vessel disease, right? Occluded right, high-grade complex circ, probably a subtotal occlusion of this big marginal. You can see some filling left to right collaterals, and then a straightforward proximal high-grade LED stenosis. Diabetic. So what are we thinking about? This is an example from the guidelines of a heart team approach. You really have to get a surgeon involved if he's stable, evaluate for 3-vessel disease involving the proximal LED, appropriate for CABG. However, surgical concerns because of critical limb ischemia, worry about the leg, need for urgent lower extremity bypass. You can make an argument to just treat the leg, or perhaps decreases risk a little bit by PCI of the LED and then proceed with urgent lower extremity bypass. But you at least needed to stop, think, make a decision about this complex patient. He comes back for a straightforward LED PCI. Now at least the LED is secure, goes ahead and has a successful lower extremity bypass. And then last case, take some time for questions. This is to represent shared decision-making. 67-year-old lady with exertional chest pain. Pertinent history, she's got inferior ischemia on a stress test. She's got preserved LV systolic function. She's on some medical therapy. She's referred for cath. What do we find? High-grade, very calcified right coronary artery. Get this mouse to work. There we go. So, decision on intervention. She's got stable ischemic heart disease, right? Moderate chronic ischemia, angina, on some medical therapy. Higher than average lesion complexity, I would argue. Certainly treatable, but treatments can include calcium modification, perhaps rotational atherectomy in this case, shared decision-making values, discussion with the patient, risks, benefits, probably no survival benefit, but angina relief, less meds, discussion with the referring physician. You comfortable with this? Decision for elective PCI made with the patient, with the referring physician for angina relief. She comes back, indeed, calcified by IVUS. You take your time, you do roto, you place a stent, and then do post-stent optimization, high-pressure balloons, and you end up with a very nice result. She did well, but you feel comfortable because you've made a good, thoughtful decision. So lessons from these cases, consider the guidelines. Remember, they are only guidelines. You can skip them or you can override them, but you want to at least think about them. Consider patient wishes, your ability to achieve a good result in a safe manner. Use all your tools, right heart cath, lesion prep, appropriate timing, and proceed thoughtfully. Thanks.
So I just wanted to open up a question to the panel just about practice patterns. So we see the guideline suggestion in terms of finding an occluded artery in a STEMI, for instance, and maybe you're cathing them a couple days later. And this is actually very common for me where I practice because I have a lot of patients that come post-TNK. So is everyone leaving those arteries occluded? Or if not, what are the scenarios where you proceed with PCI?
I can start here. So I think it depends on the presentation of the patient. If the patient is stable and if we have time to think of what to do with the patient, I'll take some time. But if the patient is unstable, my reaction is to move forward and to try to treat the patient. So I think it depends pretty much on the presentation, on the clinical scenario of the patient.
Yeah, for me, I would say it really depends on the stability. So if the patient is asymptomatic, then there's obviously no emergent need to treat it then and there. Obviously, if the patient is still having active symptoms, then that's a different conversation. Now, if they're not having symptoms, the decision to whether or not to treat or not treat, I usually use, obviously, shared decision-making with the patient's interest in mind, but you can use a non-invasive test. So we frequently use stress PETs to A, assess for viability, and then B, look at the degree of ischemia. If it's more than 10% on PET and it's viable, then we'll have a conversation with the patient to treat it or not. If it's less than that, and certainly if it's not viable, then we don't proceed.
You know, it's challenging patient population because sometimes the same reasons that they did not present to the hospital within 48 hours contribute to subjective interpretations of that timing. So I think there's a low bar, at least in my mind, to at least advance a soft wire and see if it goes. Because I've seen it the other way around. That people say like, oh, this is a late presentation, let it go, and they have a really large infarct complications.
You made a nice commentary about the importance of a heart team. That looks very different at various institutions. Some are formalized, every Tuesday morning at 7. What's yours look like?
Yeah, so we at our hospital we have a couple of ways. We have an every Wednesday morning heart team conference where we have surgeons and interventionalists in the room. The problem, right, is that most of this occurs on a much more compressed time scale. So it's okay if it's Tuesday afternoon, you'll wait till Wednesday, but if it's Thursday, you're not going to wait a week unless the patient's completely stable. So we do a lot of stable 3-vessel, stable ischemic heart disease conversations, and is multi-vessel PCI better than surgery. In the acute setting, we have a very low threshold to call a surgeon, have a conversation in the cath lab or that afternoon in the patient's room and have a full conversation. So we really try to get the surgeons involved early. Yeah, thank you very much.
All right, thank you. I think we'll move on to our next speaker. So I'd like to welcome Dr. Sandoval to talk about coronary CT for the interventionalists.
All right, thank you for the introduction. Really a pleasure to be here. I think this talk that I'm giving to you guys really reflects how the career of an interventional cardiologist is about lifelong learning, because I wouldn't be talking to you about this a couple of years, but this has really transformed our practice really in a significant way over the past, over a year or so, that we've really incorporated from a diagnostic task to a therapeutic task. And again, all of you guys are either fellows or early careers, and I will submit to you as an introduction that you want to add this to your armamentarium. The same way you have IVUS, OCT, pressure wires, CT should be part of your armamentarium. These are my disclosures. So this is what we do now. We've been doing this for about a year. It takes about 15 minutes to do it once you know what you're looking for, but it's what I like to call the one-page pre-procedural plan. And pretty much in one page, of course, some people can do more information if you want, but for clinical purposes, in one page, you have everything you need. You have a 3D MIP that shows you the anatomy, bifurcation, LAD diagonal. You know what guide you need, whether that right's anterior and what's the size of your extra backup for the left. You know the length of the disease and a multiplanar reconstruction. You have estimates of vessel lumen. You know the calcification from the CT, and you know how to achieve a successful functional result on physiology using FFRCT virtual PCI. So in one page, you can get all the information you want, and I would challenge and ask you, if you had all this information in every case that you do, whether that would be helpful and change your approach. So how we've been able to incorporate this into our practice, and again, this is something that I would ask you to consider, is because I think it was Zach who alluded to this earlier, there's a lot of heterogeneity in our interventional practice, right? There's some people that do 200 cases, a lot of CTOs. There's a lot of people that do 40, 50 PCI. Same thing, there are some labs with all the toys and tools, but there are some places that are non-surgical backup or ASCs. So CT is a tremendous tool to allocate cases and triage in what I like to think about where, who, when, and what. So in the left, super straightforward, RCA lesion, focal, no calcium. This can be done by anyone, anywhere, at any time. On the right, horrible calcific lesion all the way to the ostium. You want to do this at the primary hospital with a chip operator, early in the morning, well caffeinated with a 7 French guide, right? So you can see how CT can be very helpful to improve your day, to improve your workflow. So in my mind, the number needed to treat, like the number needed to be convinced is not that high, because you see the value of doing a complex case at 8 a.m. because you looked at the CT versus Friday at 5 p.m. Similar to the lessons that we already know from IVUS and OCT, there's no reason really not to apply them to other modalities. Of course, there's some need for data and validation, but the concepts are the same, right? Kevin and a lot of other people have done a lot of work on this and doing the MLD, but you can apply that to CT. You know what you're looking for. You're looking for morphology, for length, lumen estimates, and you can expand it to physiology because you can look at physiology based on the CT. So let's get into that. CT vocabulary. This is something that you guys need to learn. I would say that if you are saying, I want to get into this journey of CT-guided PCI, learn what a MIP is, look for your cardiac imager or radiologist, and ask them to teach you how to obtain a MIP. It's a maximum intensity projection, and in one quick image, you can see on the left, a super straightforward RCA lesion with no calcium, and on the right, you know it's a calcium nightmare. In this very simple picture, you already know what you're getting into. And again, I would argue that's very valuable information for your pre-procedural planning. Similarly, you can look at your guides, you can look at the axial views, know where the ostium is coming, you can see on the likely measure the aorta dimensions and understand what you need for your size. So again, you can save contrast, improve your procedure. This is one such example. You just take 1 second, look at the CT axial, it's a very anterior right, so you don't need to fumble around and waste contrast and radiation and resources.
You say, I need an AL1. Take 2 pictures, be done, keep going. We just need to look at the CT. And in the cath lab, we haven't been doing that. We think of it as a diagnostic tool, but it's a therapeutic tool. Same thing for MLD. For MLD, you'll apply the same concepts from IVUS and OCT. You can extrapolate all that to the CT. As you can see, you just look at multiplanar reconstruction. You can look at the length of the disease. You can look cross-sectionally for calcium. So you just from this, there's multiple softwares. This is one that I'm showing that we use in our practice. You can know the optimal angle for the PCI, the estimated length of the lesion, and a sense of the lumen size. Everything from the CT, same, but pre-procedurally. Calcification, I would say, is probably one of the major enemies in contemporary practice of optimal PCI. So if you know that you have calcium before the procedure, and again, just to echo Zach's comment, if you have this, I want this to go in the morning to Kevin, to Allison, to Manos. It should go to a high-volume chip operator, right? This should not be in your non-surgical backup low-volume lab. For CTO, actually, we have randomized data that CT improves procedural success. The only issue with CT for CTO is that it used to be that you had to be a level 3 CT reader and you had to have a super expert CT reader to look at all this stuff. This is changing. I'm showing here in this slide the new emerging softwares that are coming up that essentially with just very AI-based, you do one click as shown there on the right, it AI automatically detects the CTO on the shaded segment. You can just rotate it so you know the length and the features of the CTO. You don't need advanced level 3 imager. I love them, but this makes it easy. This makes it accessible to you. Physiology. Again, we're talking about morphology and physiology. I really always struggle with all these debates about wire versus imaging or physiology versus anatomy. It's not one or the other. It's both of them together. And CT is a great example where you put both of them together, right? You're looking at all the morphology, all calcium and whatnot, but you're looking at physiology. You can look physiology for CAD phenotyping. On the left, focal lesion, huge FFR delta CT. On the right, diffuse disease. You know that the left is going to likely greatly benefit from PCI, whereas on the right it is unlikely because it's a diffuse pattern. This is something that you could treat with medical therapy if you wanted to. These 3D models are actually very helpful. We often, including myself, prior to over a year ago, I was thinking about this diagnostically, but now we think about it therapeutically. On the left, you can see it's a tortuous right, Shepherd's crook. I need an AL1. Whereas on the right, you can see it's a straightforward lesion in the mid-RCA. I need a JR4. And as you can see at the bottom left, you know the angles for your PCI, so you can choose the optimal angle. So think about this information now from a therapeutic perspective. Something that we've been doing, and this is the reason we got into this journey, is because now we do virtual CT-guided PCI, in which we look at all these CTs, and we therefore select the stent length based on the predicted post-PCI FFR CT. And again, the value of this is that therefore, if you see on the right, we don't necessarily need a long 26-millimeter stent, as shown on the left. An 18-millimeter stent would give you the same predicted post-PCI FFR CT, and this is what we've been doing in our practice to choose the appropriate stent for the right patient. Myocardial mass is something that we're exploring. Dr. Carvalho, one of our fellows, has been leading research in these initiatives and our Center for Coronary Artery Disease team. But pretty much for bifurcations, we can also look at myocardial mass and understand how to treat bifurcations based on the mass and the lesions. We're trying to explore this more and more. And again, bifurcations is a big opportunity for this. Is this tested? We're actually, there's the ongoing P4 RCT. It's a randomized trial, 1,000 patients being led in Europe, a few sites here in the US. This is CT-guided PCI versus IVUS-guided PCI, MACE at 1 year. So hopefully this will actually provide some randomized data about the value. So I would submit to you that the past of thinking about CT as a binary test of normal, defer lap and abnormal come to the lap and we'll figure out needs to go away, right? You wouldn't do an ad hoc TAVR without looking at the CT. And moving forward into the future, we need to think about how we look at the information of the CT to improve pre-procedural planning. We're actually we just had our first CT for PCI course earlier this year. Tremendous interest. I would invite to all of you that are interested in learning more about this to join us in Minneapolis, October 24th, 25th. We'll do that day and a half of this whole experience. Thank you so much.
So, Yader, I've got a question for you. So, if you look at someone like myself, for instance, I'm getting old now, right? And I trained in the Canadian system, so my exposure during fellowship to CT was, it was there, but it was pretty limited, for instance. So if you take someone like myself or other people that are less experienced in this area, how do you get me to the point where I'm using this technology regularly and it's beneficial to me? And I also just wanted to ask, genuinely curious, is the experience for fellows quite different now where they do have a lot of exposure to this in their current training?
Yeah, so, I'm a sort of like so I got trained in CT level 2. So I was familiar with it, but I went to practice, and to be honest, I was never thinking about it in a therapeutic fashion because I'm in the lab, the room of, the truth room. We don't need a CT, right? We can figure out things in the lab. And then, through different collaborations, research and whatnot, we started looking at this and we realized that this totally changed our practice, right? Because why do I need to wing it, as we were saying before, in the cath lab, where I can know from beforehand what am I dealing with? And in our practice, it became incredibly valuable because we have 3 types of cath lab within our healthcare system. We have an ASC, we have a non-surgical backup lab, and we have Abbott, the mothership, right? So if I can allocate my cases with CTOs, calcium, critical lesions to the right lab, you can do that. So how to do this? We started in a journey. We started first with FFRCT and the models, because I think that's the easier thing to understand. And then little by little, we added, same as like the CTO staircase, you added looking at the CT and whatnot. I will admit that shown in some of the slides that some of the softwares are now increasingly, and will likely moving forward, will be increasingly facile for us non-imagers to use.
Hey, that was a great presentation, and I think, it definitely is forward-looking in terms of, I think, where we'll be 5 years from now. Just a quick question, if I want to get started to be more progressive like you are, how are you doing it now? Does everybody come in the lab, get a CT? Is it select out patients? Do you use it to stratify in patients? Kind of where do you start? What's the path forward if you're a noob that's going to try to get a program going?
Yeah, it's a great question. In our course, we talk about this, about the concept of the adjacent possible, and it seems like it's like one person, like myself or Manos, doing this sort of thing, but we have a great imaging team that they have made. I mean, we use all modalities, but they've really made put CT up in front for the evaluation of patients with coronary disease. So we have CT at the mothership at Abbott. We have it all across our metro area in the Twin Cities. So it's very accessible as accessible risk stratification tool to evaluate patients with CAD. So once you have that, then it is not infrequent. I wish I could tell you the percentage, but it's not infrequent that a lot of patients that come to our cath lab have a CT. And so to me, in my mind, there's 2 paths. Either we're going to do it status quo and I don't look at the CT, or we need to learn how to look at this. The challenge that, and Jay and others were at the course the first time, but the challenge is what softwares you have available to do that, but everybody has access to the CT interpretation software. So looking at least at plaque and calcium, it's probably a good starting point.
And how to use it for pre-op surgical planning? Will your surgical team take someone to the OR with a CT and not an invasive angiogram?
I think that's a work in progress still.
Continues to be a work in progress for us also.
Yader, can you, we talked about this at your course, but for the audience, could you share your workflow for what is the role for intravascular imaging in a patient who's at a CT, pre-planning CT? Do you use it anymore? Is it still important for validating your PCI after the procedure is done?
This is, of course, a topic of debate, but in our practice, and we actually just recently looked at our experience thus far, we've used it in all cases. CT is great for lesion length. It's really good for calcium, but something that I think we need to learn more about is vessel sizing. And I'm a big fan of putting the biggest stent I can, and I feel still more comfortable with imaging. And you still have to do the procedure and do post-PCI assessment. So again, I think CT is great for triage and planning. We still actually use pretty liberal use of both imaging and physiology for intraprocedural guidance. And we probably have been using it very proactively to also better understand how all these things correlate.
But that contradicts the protocol of P4, right? So P4 randomized people to CT exclusively for the PCI versus IVUS.
Yeah, that's in our practice.
So Yader, I think Kevin said this is a forward-looking talk. I would say that the negative predictive value is very high for CT, but the positive predictive value doesn't correlate one-to-one. I would say, at least at our institution, and we have, very modern CT software and scanners. So we have photon counting CTs, which, are supposed to be even better at looking at the lumen, less blooming artifact, et cetera. But I still find that, 1 in 3 or 1 in 4 it'll say that there's severe disease or there's triple vessel disease, and you'll find that that's not the case. Can you speak to ways to maybe minimize that, or potential software that we can utilize to leverage those problems?
It's a great point. I think everybody deals with it, including, everybody deals with it. There's issues with CT artifacts, motion artifacts, obesity and whatnot. But I think several things are happening. One is, of course, that, using more physiology on the CT will help, right? Sometimes I think we underuse it, everybody underuses it, whether that's FFRCT and whatnot. So that will help overcome some of that. And the other thing is just technological hardware improvements. As you may know, there are some of you, and I don't know whether Evan's still around, Shlofmitz, but there's some practices have already incorporated photon counting CTs. And with photon counting CTs, the ability to reduce, to improve characterization is expected to improve significantly.
Okay, thank you very much. We're going to move on to our next talk by my co-moderator on bifurcation stenting techniques.
Thanks. I went from a very simple topic on balloons to something that can't be covered well in 8 minutes. So I'll do my best. How to do bifurcation stenting well is not something that you can learn in an 8-minute talk. I think it's really one of the important charges of your interventional fellowship as you begin, and there's lots of resources for this, some of which I'll point to. So I sort of took an approach to how to do this well without focusing as much on the mechanics, because the mechanics are outside the scope of what we can accomplish well in 8 minutes. But I think there are ways to, in a utilitarian way, approach bifurcation PCI, understanding the hazards of it, what makes it fail, and that there are metrics of how to do this well. So we know that bifurcation PCI has higher rates of adverse events. So your patient, by the fact you're doing bifurcation PCI, is more likely to come back and their stents are going to be less durable. So the stakes are higher. You need to do a better job, I would argue. Similarly, intravascular imaging improves complex bifurcation PCI outcomes shown in the past year and a half in the October trial. It's no different than any other PCI where imaging has an important point in making people have more durable outcomes. So if you've got a patient more prone to stent failure and you have a tool that's going to make stent failure less common, why not image every case, but certainly your bifurcation PCIs? And so we spoke a little bit about MLD max as it applies to CT. I'm not going to go into this in detail. There's a conversation later this afternoon about image-guided PCI. I'm sure some of this will be covered. But I just want to highlight the fact that there's scripted ways to do IVUS or OCT-guided PCI with the goal of getting your stent optimized to a place where it delivers better outcomes. That's what was applied in the October trial. So we don't just use the imaging, we use it prescriptively toward a goal. And this really becomes operant in left main PCI, where many of us, I think everybody on the panel would agree in the current era, it's unconscionable to do a left main PCI without IVUS or OCT. And so if you think about that, all right, I use it, but how do I use it? And there's really clear goals in terms of the areas you want to achieve in a left main bifurcation PCI, above which your patients become free from MACE. And so to use these tools, you need to use them well in understanding what the data is to show you how to get to a goalpost or to the finish line of what constitutes an image-optimized PCI. So just real quick with bifurcation anatomy, you've got a proximal main vessel, you've got a branch, and then there's angle, and then there's the confluence polygon, which is sort of the area where the two bifurcate. This sort of just sets a little bit of the nomenclature. There's lots of classification schemes. I tend to be a simple first person, so I sort of favor the Medina classification. That's what I hear most experts in the field continue to use. This is classified based on whether there's proximal main branch disease, distal main branch disease, or side branch disease. And you can go, it's just bimodal, 1, 1, 1. It's really straightforward. But it really talks about the fact that when there's disease in all three limbs of a bifurcation, you're more likely to have complexity and more likely to have pinching of the side branch if you go to a provisional approach. The angle is another important feature between the side branch and the main branch, which is not covered in the Medina classification. So, you probably already in your interventional fellowship have heard people advocate for keeping it simple, try to do provisional whenever possible. And there's an older database which suggested that that delivered better outcomes. I think with modern techniques and better understandings and new data, that's actually not the case. For complex bifurcations through something called the definition study and several meta-analyses, it's demonstrated that a two-stent strategy for two vessels that are large with Medina 111, you deliver better outcomes with a two-stent strategy. So it's incumbent on us to be able to do that well. And so if you think about the anatomic features that influence bifurcation strategy, it's the vessel size and diameter, how much myocardium subtends, variations in sort of how big is the side branch, how much disease, will it be hard to rescue it, what's the chances it's going to go down, and then things that can happen during the case, such as plaque shift dissection and side branch loss. These are all the things you're integrating in terms of whether you're going to go with a provisional strategy or a potential two-stent technique. This is an algorithm that Jason and Manos, myself, and Ethan Korngold put together. It just came out of a course that we do, and it's really meant to be simple. Do we need to preserve the side branch? A 1-5 diagonal should be ignored in most cases. Then it's provisional. If you care about the branch, then do I need a two-stent strategy? If you're thinking it doesn't have high-risk features, it's a Medina 110, it's a broad angle, no, you can go with a provisional strategy. But if you're thinking that you're going to lose the side branch, and most importantly, if there's a risk of losing it when you stent across it, it favors DK crush, which we'll go into a little bit. The two main side branch techniques that we're going to talk about for two-stent techniques is DK crush and Culotte. And so we'll also go over TAP a little bit as a bailout. So provisional is real straightforward. You just choose the stent size based on the main branch distal vessel size. Don't size it up here. That's when people get in trouble with perforations. You place the stent, you leave a wire in the side branch, you dilate it, and then you do want to pot it proximally so that the stent matches the larger artery before before it tapers. And so when to rescue, I would just advocate if you have a large branch that gets pinched with reduced flow and symptoms, you clearly need to do something about it. We do use a decent amount of physiology. We all know that the angiogram is not a good predictor of ischemia, so if there's a question of whether the side branch is pinched importantly, put an IFR or an RFR wire down there. Additionally, the ways that we can rescue is simply with a balloon. You can go ahead and balloon it if you've got a little bit of pinching, you think it'll respond well to balloon angioplasty. This is relatively straightforward. Leave your wire, rewire, balloon it. What you don't want to do is skip the final kiss. This is just to say that balloon out the side of a stent is bad because it raises the abluminal stent away and creates a situation where you deform the stent and it puts patients at risk for stent thrombosis. So if you're going to balloon out the side, you always have to do a kiss. This is something you probably already know, even at that nascent point in your interventional fellowship. So if you lose a branch or it pinches substantially, what are you going to do about it? This is an attempt at provisional stenting. You see that it didn't go well because the diagonal went down. The ways to bail out are TM protrusion, Culotte, or reverse crush. So if you're going to take a provisional strategy, you need to be prepared for the fact that, as in the prior angiogram, when you lose the game, you need to know what to do about it. And I'll go through these relatively quickly. TM protrusion is simply to wire through the side of the stent, balloon makes some space, put a second stent in with an adjacent balloon in the main branch, deploy the stent, pull both balloons back, and inflate them again. The negative part about this is you do get a little bit of a neocorona. At our PCI master's course, I once asked Manos to give a talk on TM protrusion, and he's a gentleman. He politely said no because he hates TAP. The reason he hates it is because it can be a pain. If you actually create too much of a neocorona and you hang it out too much, it makes it miserable. And so we try not to TAP. It's a little bit less elegant. But in very broad bifurcations that are more toward 90 than narrow, it can work out okay. This isn't a case where you can't use a T-stent because it's got a little bit of an angulation to us. So you can think about what angles this applies to well. The side branch has to be a broad angle as opposed to a narrow one for this to work. If that doesn't work, then you can bail out into a Culotte, which is one of the major two-stent techniques I'll go through. I'm going to go through these relatively quickly, not to go over the details so much, but to talk about the value proposition of when you use one technique or the other. A Culotte is helpful if you don't think you're going to lose your side branch. It's to be used when there's low risk of side branch loss because you have to stent across that branch before it has a stent in it. So if it's going to pinch substantially, it's a bad choice. It's also a bad choice if the side branch is a lot smaller than your main branch because your side branch is going to have to come up into the main branch, and if you have a 2-5 diagonal going to a 4 LED, that stent's not going to stretch very well that way. And so we typically use it in branches which are 1-to-1 size where you don't think that the branch you're stenting across is going to misbehave. The technique that you all need to be proficient at because it's the best one for emergencies, it's the best one for when you have dissections if you predilate, is DK crush. It takes the most steps. I always joke with my fellows, I hate DK crush because if you read Manos's book or you look at his video, it's got 17 steps. To do it well takes a little bit of time. It's kind of fun and elegant once you get good at it, but there are really no shortcuts. And the first kiss initially is to make the subsequent crossing easier. Stuff you can read about in detail as you study these, which I advocate you all should as part of your fellowship. Culotte stenting is just straightforward. You've got a double layer here with pant legs into both vessels. I won't go into this in detail. Great YouTube video, great resources. There's a wonderful Jack review which goes through this step-by-step that I would advocate everybody learns. DK crush is just another variation of bifurcation stenting where you first stent the side branch, you put a balloon next to it, you crush it, you recross, and you put the second stent in. There's 2 kissing steps in here. The first is to make recrossing easier. A lot of what we do in bifurcation stenting is to deal with difficulty in getting across stents again. There's some techniques to do this. If you're having a hard time rewiring, make sure you're not under a proximal strut. You should pop before you try to rewire to make sure you don't get under the strut. You can use a dual lumen microcatheter to get past the proximal segment if there's any question. Microcatheters make wiring through side struts really easy, as do in some cases polymer jacketed wires. I tend to like a Pilot 50 or a Chien Black if I can't get a regular workhorse wire through. If you're having a difficult time recrossing with the balloon, worry about wire wrap. That was addressed in the guideliner segment. Think about a microcatheter. A lot of times if you take a Turnpike or a Corsair through the stent struts, it can dilate. It can allow your Takero, your low-profile balloon, or your next balloon to go well. And if you're having a lot of trouble, you can actually blow up a balloon in one of the branches, anchor the guide, and just shove something through. That works really well. We tend to do all of our bifurcation stenting cases at minimum in a 7 French guide. Most of that can be done readily radial, so I would advocate make your life easy, go 7 French when possible. So by summary, provisional is reasonable for non-complex lesions. You need to know how to convert your provisional to a 2-stent strategy. You want to apply an algorithmic approach based on the Medina class, the vessel size, and the risk of side branch loss. And if you have dissections, just know DK crush is the best way to deal with it because you won't lose access until there's a stent in the branches. And so you really want to be able to do these in stable cases and take your time so that when you dissect someone's left main with a guide, you know how to deal with it quickly and you're practiced at it. Thanks very much.
Okay, thank you for that excellent talk. I have a question for you, Kevin, actually. So when you look at all fellows coming out of their training programs, I would say there's probably a wide variation in exposure to bifurcation stenting and also as first operator doing those procedures. So tell me about how a fellow coming out of training can progress in terms of their ability to do these, because otherwise what you see happen is at a staff level, there's people who just repeatedly do provisional even when it's not indicated with suboptimal outcomes, or they actually avoid putting a stent all the way down the entire disease segment so they don't stent across a branch and those kinds of things that aren't good for patients.
You know, competency in this is not built overnight, and there's certain difficulties of bifurcation stenting which are well identified, for which, like anything in interventional cardiology, there's typically a little algorithm for. I tried to take you through some of those. You know, can't get a wire across the stent, some things you can do, some tricks. Can't get a balloon across. There's multiple tricks. And so if you haven't been exposed to it, that's okay. Reading, going to courses, watching YouTube. And there are some great training courses where we've built live models where you can practice doing this in plastic and actually see what the stents are doing. So I think you should be able to, by the end of your interventional fellowship, even if you've only done 10 DK crushes, be able to, you know, articulate with some practice what the steps are so that you're able to execute it. And then within those steps, okay, I just placed my main branch stent across the side branch that I crushed. What are the potential pain points? How am I going to overcome them? Because you will bump into those things. So I think this is mature enough now that I think lots of people have developed teaching content which can be really helpful, which you can use as a supplement if you don't have the training experience in your fellowships, because we would really like to have all of you to be able to do this well. I was talking with my CHIP fellow who knows Allison, former, and I was saying, oh, I'm with Allison now. I was like, what are you doing? I'm like, oh, we're doing a fellows boot camp. This is really fun, because there's a lot of joy in kind of being able to teach what we've learned. But I also made the comment to him 5 seconds ago by text that someone's going to have to take care of me someday. So we really want you to be able to do this well. It's important for you and your patients. And someday if I get sick, also for me.
Allison, can I ask you something? Because you guys have been using drug-coated balloons for a while, right? So do you feel that this becomes a 2-stent strategy becomes a lost art as people just do drug-coated in the side branch?
Actually, no. So I think the more experience you have with DEB, you see a wide spectrum of value and use to them, and times when they're not going to be the full solution. So oftentimes, for instance, I actually use them a lot in side branches, so don't get me wrong, especially ones that are slightly on the smaller side or where there's a desire for any particular reason to reduce the procedural complexity a little bit. But I mean, I see a ton of dissection from DEB, even when you're being careful, especially if the side branch is actually diseased, and there is a little bit of a nuance to it and technique. You can get better at reducing that, but it happens very often. Now, what the implication of that is will probably come, out of further study. Maybe there's dissections that we can leave like that are perfectly fine, and others that we can't. But I don't find that they always keep the side branch open for me, and I do find that there's a lot of issue with dissection. So there's certainly still scenarios where I need that additional stent, but there's a lot of times, yes, when I'll get away with using them in smaller vessels, or again, times when I just may not want the full complexity of a two-stent strategy. One other question I just wanted to bring up, maybe Yader, you could tackle this for me, but whenever we talk about two-stent strategies and bifurcations, a controversial thing that comes up is jailing wires or not, and that's a big thing that fellows may ask about. So do you jail wires when you do these interventions, and why or why not?
So typically, in our practice, we usually, if there is a lesion in the side branch, we use to wire, so we obviously wire the side branch as well. And then it depends on the situation if we gel the wire or not. One of the most important things, which I learned during my general interventional fellowship, is when you are pulling back the gel wire, be careful with the guide position and disengage a little bit if you see that it's pulling back the guide inside. Another question I wanted to ask about the panel, one thing is, like, if you see that the side branch is a little pinched, do you assess it with physiology? Do you assess it with imaging? Do you do both? Which one do you trust more? Or do you just deal with angiography? And another question based on Allison's comment is that if you do DCB in the side branch, do you image it afterward, or you'd rather go with angiographic result?
Jay, are you a physiology side branch guy? Katri?
We do quite a bit of also physiology, particularly now with the, we actually have a grant that we're looking at angiographic FFR and side branches.
We try to keep it simple. I think that if you have TIMI3 flow and no EKG changes and patient stable, we tend to just leave it if there's TIMI3 flow. That's just based on the recommendations of the European Bifurcation Club, but that's just my anecdotal practice.
Yeah, I mean, it all depends on the anatomic subset, so it's not, all size fits all. But if you look at outcomes based on physiology, for bifurcations, the outcomes are fantastic. So if you look at a pinched circ, say you're doing a left main, only 1 in 4 pinched circs will actually be physiologically active. And so if you want to make it simple, you can use physiology to minimize the complexity.
And I think that if you're thinking of using a drug-coated balloon, you should do the imaging up front. I think that the key is a good preparation of the lesion. If you have a good preparation, your outcome is going to be good. I would capitalize much more on the pre-treatment to understand what's going on, if you have the dissection before doing that, because if you do that properly, it's almost natural that the post-image is going to be good. If you don't have a good result prior to the DCB, you may have a dissection and everything can go away. So I would capitalize on the pre-imaging in this situation.
Awesome, thanks everybody. We're going to move on to Jimmy Kerrigan, who's going to talk about angiography and PCI in the post-CABG patient. Thanks, Jimmy.
Of course, thanks for the opportunity to be here, the opportunity to chat. And Allison, on your last question with regards to gelling side branch wires, wanted to caution people about gelling pressure wires in that situation. The way that those are manufactured, there's a small cutout where it can sense the pressure with optical or piezoelectric technology. And that's a spot that can get hung on a stent. So when you pull it out, the tip of it stays behind, it unravels, and that's never a good day. But don't do that in a post-CABG patient either. So a question for the room. I know I've talked to some of you. How many of you are general fellows? Raise your hand. How many of you are interventional fellows who snuck away 2 weeks into it? All right, perfect. So I was given the task of talking about angiography and intervention for patients who are post-bypass. So I do want to spend a little bit of time on angiography in addition to the PCI aspect, because if you don't do a good job getting an angiogram, you can't effectively treat the patient. And one of the things that I fear is being taught still in certain institutions, and I trained in a place where we were given both of these options, was how to get some of the angiography from the radial aspect. So a lot of attendings still nowadays say that this is a post-bypass patient, I'm going to go groin. And what I'm here for the first couple of minutes is to talk about that you have options in that situation to do a better job, and potentially using some technologies or catheters that you might not be familiar with. So I wanted to point out one in particular, the BC catheter, Bartorelli-Cozy catheter, which is a purpose-built catheter for engaging the IMA from the radial. Initially designed to go from the right radial to the lima, but you can use it on the ipsilateral IMA. It engages much more effectively, definitively, and selectively than the IMA from the groin does. And again, I have to credit Jay Kotchery with teaching me about this catheter. And nowadays, whenever I'm doing a case that has an IMA, if it's left radial, or excuse me, a lima, we're going left radial. If it's a rima, it's right radial. And then we can debate on the panel about for patients who have bilateral IMAs, which hopefully we're using frequently, whether it's better to go from one side or the other or just go groin in that situation. So if you don't have access to the BC catheter for angiograms, I would encourage you to get that in the cath lab. It's a diagnostic catheter. It's 5.2 French, and it does engage the IMA quite well from either side. So getting those selective angiograms is important. Also, speaking specifically to the left radial, things that people worry about when going from the left radial with regards to angiography is being subselective, finding these bypass grafts. And as you know from doing cases from the left radial for diagnostic cases otherwise, it's generally speaking, outside of engaging the IMA, very similar to doing a diagnostic catheterization from the groin. When you're looking at the left main and the right, a JL4, JR4. Tiger Jackie, the unitorque catheters are less feasible and don't fit as well. And when you're looking at the bypass angiogram, generally speaking, for right-sided bypasses, especially if downgoing, a multi-purpose catheter, A, if it's a man, B, or excuse me, if it's somebody over 5'6", B, if it's somebody who's 5'6" or smaller, is able to engage that selectively for the majority of people. Looking at the left-sided grafts as well, the multi-purpose catheter, again, many will say you can do the entire angiogram with a multi, can get those left-sided grafts as well. Sometimes an AL1, an LCB, or a JR catheter is also useful in that situation. So again, running through a very quick angiogram. This is a patient that we did angiography on previously. So when I'm doing the diagnostic angiogram, looking at the IMA, I tend to start in an AP projection to engage and look down there. In this case, don't pan me for panning, but didn't know it was going to be a CTO when we started. So an AP projection, and then what you'll see as we do the graft angiography is you want to get contralateral views, usually LAO, RAO, and then look at the native vessel distal to where the graft anastomosis is. So in this situation, looking in a more RAO projection allows us to see the septal collaterals, but also the body of the LAD and the IMA itself. And then more of an LAO projection would let us look at the anastomosis. Moving on, looking at grafts to the left system, you want to start again RAO, LAO. In this situation, a graft to a marginal branch. You then would want to look in a caudal projection to look at the way that the graft anastomoses with the obtuse marginal and the way the OM itself runs out as well. But again, looking in multiple angulations to avoid finding hidden or missing hidden problems in the graft or in the native vessel itself. Similarly, as I had talked about, the multi-purpose on right-sided grafts is quite good with regards to engaging for angiography and then also for intervention, as we'll talk about in just one slide or two. So again, multiple projections, want to understand the angiogram. We get referred patients for CTO, for in-stent restenosis, and sometimes the angiogram is not interpretable and has to be repeated, so hopefully we can avoid that. All right, so angiography. If you do a great angiogram, you know you need to do an intervention on a patient who has had bypass. What are the things that I wanted to talk about? The use of radial artery access. What's the data for radial artery access specific to the bypass population? How do we prevent no reflow? How do we treat no reflow? Again, would love panel discussion with regards to the use of filters. We'll talk about a little bit of guidelines and data. And then the use of stent sizing and intravascular imaging. What is the importance in preventing complications in the patient population where we're intervening on vein grafts? And then a quick pearl at the end. So this is an analysis that came out last month from the Japanese version of the NCDR, looking at 2,300 patients who had PCI after bypass. And looking at the patients who had PCI after bypass, when radial arteries were used, there was a 75% reduction in major bleeding, 80% reduction in access site bleeding, which led to an overall 50% reduction in MACE. So it is safer for our patients to do their PCI from a radial approach as long as it is feasible to do so. Looking at the other confounders, there's no difference in death, shock, or non-access site bleeding. So this really was driven by access site bleeding. So again, as we had talked about with diagnostic angiograms, people worry about going radial and then being able to intervene because of support, because of length, and because of lack of familiarity. Similarly to when we're doing the diagnostic angiogram, if you're looking at a vein graft and you're intervening via the vein graft or on the vein graft, using a catheter that is shaped appropriately is incredibly important. Again, generally speaking, a multi-purpose for right-sided or down-going grafts, an AL catheter for left-sided or the more horizontal or up-going grafts. For patients where you're going down the IMA in order to intervene on the IMA, which happens incredibly rarely because there's very little perivascular inflammation due to the lack of fat on the IMA, but more commonly on the AD distal, the VB1 guide catheter is a specially shaped guide catheter from the ipsilateral IMA that sits quite well. It is a bit aggressive, so sometimes after getting the wire down, I'll pull back a little bit, potentially use a guide extension catheter, as you just taught us how to do that, in order to make sure that we're not going to dissect the ostium of the IMA. And then the liberal use of guide extensions, as I had talked about, because sometimes support can be an issue, especially for higher rising vein grafts. So use guide extension catheters, use your microcatheters, exchange for the wiggle wire so that you can deliver the equipment that you need in order to succeed, and you're not fighting with the guide catheter as well. So the use of filters used to be relatively routine for vein graft intervention. The 2021 revascularization guidelines downgraded the use of filters from a class 1 recommendation to a class 2A recommendation. So I currently think of it like routine thrombectomy. We don't do it routinely, but you do it when you need to. And this was based on a meta-analysis that was led by Tamir Paul, a cardiologist who's actually one of my partners now, looking at over 20,000 or 50,000 patients, and there was no difference with the use of embolic protection devices with regards to overall death rates, MI rates, and MACE rates. So again, don't kill yourself to do it. Definitely don't kill the patient in order to get it down from that standpoint. So how do we prevent no reflow? This is data from 2003 looking at a question of direct stenting versus conventional stenting in 220 patients. What was found at that point is directly stenting the vessel led to a reduction in rates of no reflow. It was safer for patients. Further data may have called that into question. For patients where we're doing vein graft intervention, specifically the use of vasodilators, sodium nitroprusside, verapamil, et cetera, is important in order to reduce the chances of no reflow, whether you use a filter or not. If you get no reflow, the treatment, if you have a filter in place, often is because your basket is clogged. So taking a dual lumen microcatheter or an aspiration catheter, removing the schmutz from inside of that basket can help as well. And then also, as Jay Kotry talked about, having that dual lumen microcatheter distally allows us to give those drugs. There's an algorithm that we go through here. Generally speaking, if my patient is not hypotensive, I'll use nitroprusside. If they are hypotensive, epinephrine is a great vasodilator. Just don't put them into VFib ideally. And then stent sizing. So when we talk a little bit later, Evan will talk about the use of intravascular imaging and physiology, and Luis will as well, with regards to how do we size these vessels. Generally speaking, we want to go to the distal vessel and downsize slightly. When we look at a vein graft, there's data that says that if you go even a little bit smaller, the 0.9 to 1 times the distal reference, you can reduce the chance of MI, reduce the chance of plaque protrusion, and then reduce the chance of malapposition. So this is that 1-to-1 or slightly smaller based on the distal lumen reference vessel. So overall, I would still recommend that just because a patient has had a bypass doesn't mean that you have to go groin. Use the right guide for the right graft and be thoughtful with that selection process. You can never have too much support, so also a good place to practice your guide extensions and microcatheters and supportive wires. Use an EPD, but don't hurt the patient in order to get it down. Prevention of no reflow is key, but treatment may be needed at times. And then I would say that I image all of these cases just like any other native vessel intervention to guide purposeful undersizing. And because this is a talk about vein graft intervention, just fix the native and forget about the vein graft. Thanks for the opportunity.
Thank you so much. That was a wonderful talk, and you can see that you're going to need your full spectrum of skill sets sometimes for these interventions on these grafts. I was just going to make a comment more so, we've presented lots of data here for radial approach, and we hear the comment quite commonly, fix the native, but it is important to remember as a fellow that we rarely speak in absolutes in interventional cardiology, so you need to have that excellent femoral skill set for when your radial approach in a bypass patient is not working out. You need to have experience with that and be able to do it safely, and similarly, not every scenario you're going to be able to fix the native vessel, especially if you're not a CTO operator. So if you're coming in for STEMI in the middle of the night and the native vessel is completely occluded, heavily calcified, you do need to have this excellent skill set to treat a graft well with PCI and to manage the complications as you intervene on the graft. As a side note, if you've ever put an imaging catheter into a graft, it's extremely interesting. They're very fascinating, so something to try sometime for sure.
Jimmy, I wanted to emphasize something that you already point it out, but since there's so many diagnostic fellows in the room, there's a huge variability in terms of how many surgeons use graft markers versus not. So in our region of the country, they don't use graft markers at all. Where I trained in the Southeast, they used exclusively graft markers. So, that has a huge impact on how efficiently you can do a cath on a post-CABG patient. So if you've got markers, it's pretty easy, okay? If you don't have markers, it's quite a bit more challenging. And what's even more challenging is if you have a patient who's had a prior angiogram and they've had a bunch of obscure projections taken and nobody knows how to get back into those grafts. So do yourself and your colleagues a favor, shoot the right coronary graft in a straight LEO30, shoot the left coronary grafts in straight REO30, so we all know in the future how to get in. You'll thank me for this later.
One other thing is sometimes these bypass patients will come in and you don't know their graft anatomy. They just say that, I've had a bypass ×4, but you don't really know what the actual bypasses are. It may not even have been bypass ×4. So an area that we find very useful for CT is specifically to figure out what the anatomy is before bringing the patient to the lab. And if you know that the graft is occluded on CT, then we don't even spend time fishing for it unless we anticipate we may need to use it as a retrograde conduit for a CTO PCI.
And if you don't know the anatomy, I would suggest you to go femoral, because if you go femoral, you can go to easily to the lima, to the rima, to everywhere. Because if you commit to the left radial, for example, if the patient has a rima, you'll be in trouble if you don't have those dedicated catheters. So if you don't know the anatomy, in most of the cases sometimes, then I would suggest you go femoral.
And Jimmy alluded to this, but many of us that have CTO skill sets have a true disdain for vein graft stenting because the data for the durability is miserable. You can expect if you put a stent in your patient's vein graft that more than 60% of them will close in the next 5 years. They still can be used as retrograde conduits, but that's often associated with an MI and repeat procedures. We do have people sent to us for vein graft multi-layer stent brachytherapy. That's a really bad idea. Just open the CTO, and they do serve as good conduits to get retrograde in those cases. So I think, if you're stuck in a place where you're stenting a vein graft in an ACS patient, Manos has a nice series of forward-thinking papers and registries where, at the time of the ACS, fix the graft, but don't let the patient with the degenerated vein graft go out into space and never come back. Try to get them into someone to have a purposeful conversation about whether a CTO PCI would be warranted before the thing closes and they have yet another ACS event. And so that's kind of the way that we've been progressing our practice to try to get ahead of this because we know these are not going to be durable. That's great. Any other comments on that question? Yeah. Yeah, sure thing.
My comment is for all the diagnostic and general fellows, the takeaway here is do the diagnostic cath well the first time, okay? Because it helps. Half the time we joke in our cath lab, as you guys are alluding to, this person just needs a diagnostic heart cath because at the outside place they didn't do a good job taking appropriate views and laying out anatomy. So do it right the first time. You're doing the patient a disservice if you don't do that. My second question is, what's your room setup for left radial?
A work in progress. So I'm a huge fan of distal left radial personally, just for my comfort and the patient's comfort, getting access in the left groin hole, using ultrasound for distal left radial. Otherwise, depending on if I'm doing a left and a right heart cath from the left side, I'll get access in the traditional pseudo snuff box it, pull it over, and then work from the right side. There's a couple of purpose-made boards that go behind the elbow to support, or you can use pillows or packs of towels. I don't know if anybody has a perfect solution.
The hand surgeons have these things that look like finger traps, like you put your fingers in them. They used to call them like Chinese finger traps. I don't know if that's probably not politically correct, but that's what they were called. And so they're these little nets that will grab your finger, and it's attached to a sterile piece of rope. And you can pull the hand across and make it almost like a left femoral case. Even though I'm tall, I hate to bend over trying to engage an IMA, especially if it's a retrograde through something from the left wrist. So, in the worst cases, your arm is over the patient, your axillary is getting baked the whole case. So there's lots of ways we've all adapted, I think, through a substantial disdain for left radial to make it more comfortable for us and reduce your radiation. We use Rampart for all of our known PCIs, and you can adapt it even for that. Rampart's just a screen that allows us to be lead-free. And so there's some innovative ways to do this, and I'm sure colleagues might have other comments. Allison, you were going to say.
Yeah, so I agree with everything that was said. I'm not sure if it was mentioned, but another thing that sometimes we'll do is take a longer sheath and extend it out from the wrist a little bit to give us a bit more extra reach. These cases can be really tough. I mean, I'm not terribly short, but I'm not terribly tall, and I find when you have quite obese individuals doing a long case, climbing over them essentially to get to their left radial can be really hard on your back after a long while in practice. So you have to do your best to set up beforehand so that they're well supported and they have the best reach over to you that you can. I don't have a great setup for this in my lab. Honestly, we are in the pillows and ties and clips mode. So if anyone wants to offer me a nice left radial support system, I'd love that.
It's something that I hate being uncomfortable during long cases. So even if you don't have the finger trap devices, you know those posies that you get woken up into in the morning to renew the restraints on the patient who's delirious? Everyone knows that. You're all interns, right? You get the 2 AM page that the posy needs to be renewed, and they wake you up to do that. So if you do a radial case and you put those around the base of the hand, it's not sterile, but you can pull it across, put it over a towel, and achieve the same thing. And so there's also something called the Cobra board, which is a thing that supports the triceps of the patient's arm doesn't get asleep or tired. And so a combination of these things can make radial access really easy. Distal radial is a great solution. If you're facile with that, it's more comfortable for the patient because they can roll their hand in. So you need not make left radial be torture. To Jimmy's point, I think there still is a very good value proposition for ease of patient experience and less bleeding for radial, even in a bypass case.
Or put that restraint on the upper forearm, pull it across the shoulder, and our radial board has a cutout there that we tie it off to and then hold it there with the Cobra behind it so that it doesn't fall away. But sometimes getting access on the Tennessee mediums as they breathe for distal radial is like cathing on a cruise ship, which is great.
What do you guys do, Darsh?
Yeah, it's the Cobra and the finger traps, and I think it works exceptionally well. I think you just have to do it repeatedly to the point that your staff becomes very comfortable, and then also figure out what works best for you, but that works the best for us.
Judith, what do you do in New York now for left radial?
So it's an ongoing problem. We do need to persuade the nurses to put extra pillows and because our back is killing us. But I think the most useful solution is that we use an extra towel, which is going around the patient's wrist after we got access, and then we move the arm across almost to the left femoral height. But in case of obese patients, it is a real issue, so we are still figuring it out.
It's ripe for innovation. Awesome. All right, I think up next is Dr. Hall is going to talk to us about in-stent restenosis. Thanks, Jimmy. It's great.
Oh, sorry, I didn't realize it was already up there. One moment. Okay, so thank you very much for the opportunity to speak on this in-stent restenosis topic. So why do patients get ISR? So first of all, keep in mind there's clinical factors. So people can have terribly controlled cardiovascular risk factors like A1Cs of 13 and smoking 2 packs of cigarettes per day. Sometimes there's only so much you can do. However, a lot of ISR comes down to technical issues with the previously placed stents. So commonly you'll have things like underexpansion, undersizing, stent fracture, for instance. And then you have inter-stent factors. So over time, these patients can develop the same disease process within the stent with neoatherosclerosis. And of course, you can have neointimal hyperplasia, for instance. You can actually have extra stent factors as well. So the patient may just have very small diffusely diseased vessels or heavy calcium in the wall of the vessels or nodules that are impinging into the lumen and haven't been adequately modified. So why do we care about this so much? Why not just quickly balloon it and get out of Dodge kind of thing? Well, the issue is that when you intervene on these lesions compared to de novo lesions, the patients just generally have much poor outcomes. So that includes things like major adverse outcomes, but especially your TVR rates are very high, up to 22% out to 48 months of follow-up. So these are repeat offenders and repeat customers within the cath lab. So also, especially within North American practice, for instance, we have a tendency to throw more metal in these individuals, and we don't always do the best job of how we do that. And the more layers of stent you put in, especially once they're coming back for their third reintervention, keep in mind how high the rates of TLR are for those patients. So we need to figure out what to do. So the best thing here is prevention, and we've all harped on this today, but you need to do an excellent job the first time around. You don't want to end up with a stent that looks like this here. You want to image throughout your intervention and make sure you get an excellent result the first time around. But now you've got an ISR case on your table, so what should you do? First things first, again, grab your imaging catheter. And this is because interventions on ISR have better outcomes in the data if you actually use imaging versus not. And more importantly, your imaging is going to actually help you figure out what's going on. Truly, it will. So just look at this IVUS example, for instance, up here. The mouse is a bit finicky, but if you have this circle floating within a circle, you can see that someone's put a terribly undersized stent in there. If your stent is quite constrained by extrinsic factors like calcium, for instance, you've got an underexpanded stent, and then you've got your other findings like neointimal hyperplasia and neoatherosclerosis, which I'll show you in a second on OCT a little bit more evidently. But here's OCT imaging within an ISR segment. You can see this thick, homogeneous, bright tissue throughout the lumen, which represents NIH. By comparison, over here you have neoatherosclerosis with a darker lipid-rich plaque deep to a bright intima. And you can see other details, for instance, such as thrombus presence. So imaging is really key to figuring out what the heck is going on with your patient. Next, once you understand the process, you have to size your vessel. And again, imaging is going to be key for this because you want to choose what size balloons and intervention tools you're going to use, and ultimately what's the appropriate stent if you're going to put another stent in this patient. So once you've got all that information, you're ready to modify and expand any old stents. There's algorithmic approaches to this, starting from simple with pre-dilatation with small balloons, maybe just to get your IVUS down, going on to NCs, specialty balloons, cutting and scoring, and right down the path with your very high pressure OPN balloon, laser, lithotripsy, atherectomy, et cetera. And well down the line, if your patient is having recurrent ISR, despite efforts to expand the underlying pathology, they may need a consideration of brachytherapy in certain instances. So for noncompliance, we're all familiar with this. Just a couple of quick tips. For ISR, you may want to do more prolonged inflations or multiple quick up and down inflations. Sometimes taking a shorter balloon can help you concentrate the force a little better at the target region. And keep in mind, you're not putting these NCs in and just going to 12 atmospheres. That's rarely going to help you. You do want to take them up to higher atmospheres as well. If you're going very high, you may undersize a little initially. We talked earlier quite a bit, Kevin outlined the role for scoring, cutting, and chocolate balloons and what they look like. OPN, again, is graded for up to 40 atmospheres or 35 atmospheres clinically, and I would just advise you, if you're working with it at those pressures, maybe to consider undersizing it by 0.5, at least initially when you're using it. Lithotripsy has been talked about fairly extensively as well, but this is a great tool to us now dealing with calcified lesions, in particular in ISR setting and underexpanded stents. For laser, it's important to note the benefit potentially of simultaneous contrast injection during your laser modification for ISR because you get these bubbles that form that provide further mechanical force into the wall and modify your vessel compliance. Atherectomy is used further down the line, typically for stent ablation, especially if you've got a really undersized stent in there. There is a little bit higher chances of things like slow reflow or burr entrapment, and you do tend to use larger burrs here, like 175, for instance, if it's rota. So generally, we do it down the line in the algorithm. Subintimal techniques are at your disposal if you have that skill set. So you can get a wire in behind the stent, do some ballooning to modify the plaque beneath the stent, or you may even choose to re-enter around the stent and deploy a new device, crushing the old one to the side. CABG, of course, is still there for you if you try all of this and you're not getting where you need to. And once you've done adequate modification, you need to use imaging to confirm that for you. So you want to see something like this. You've got the old stent fully expanded and opposed to the wall before you go putting any other devices in. So then you have to decide whether you're going to put a new stent or a DCB. And I would say this is an evolving area and evolving practice pattern. My general advice would be if you have multi-layer ISR, if at all possible, avoid putting more metal in there and use a DCB. If you've got a single layer of stent, and especially if it's older and you've got an excellent expansion after your modification, then I think it's quite appropriate to put a second layer of stent. Do not put a third layer of stent in there. So some cases. Okay, so this is a poor individual. This is a man who got his LAD peppered with 225 stents. And you can see with the naked eye that these stents are much too tiny for this guy's vessel. And there's further weird things happening here. Like there's a weird step down here, either a small gap or a fracture in the stent potentially. And he's come with an anterior STEMI, so unfortunately, nobody did him any favors with that original intervention. And you can look here at the IVUS. I do have better IVUS now, don't worry, but this is the Volcano IVUS. And as you watch here, you can see there's an egregious undersizing of the stent, okay? Especially as you get in the proximal vessel, look at it just floating in the LAD. Importantly, I don't see a ton of calcification or things that are gonna prevent me from dilating this. So I actually just treated this case with appropriately sized NC balloons and was able to expand the previous stents relatively well. And I deployed 3 new DES here because they were so egregiously undersized and I was worried about fracture and other things. Speaking of diagonals, this was one that I did a DEB on, and you can see, unfortunately, it's roughed up and dissected. I was not thrilled about that, but I also felt it was too small a vessel to go putting all extra metal in the context of existing ISR. And this patient's doing great. I saw them recently at 1.5 years out. This is an individual who had a 225 Taxus stent placed directly without any pre-dilatation in their LAD. And you can see the LAD is completely occluded now, actually, and they're having significant angina. So here you can see that as you watch, there's a lot of negative remodeling and disease throughout the vessel in general, but as you get into the proximal segments, you can again see that once you see the stent here coming up, it's significantly undersized for the patient's vessel as well. And again, not a ton of calcium in this case, and after serial dilatation, I was able to dilate it adequately by IVUS confirmation. I placed 2 additional drug-eluting stents, and here's a scenario where I do like drug-coated balloons. I treated all of this down here with DEB and got a nice result. This is another case where a male patient had 225 stents thrown through their proximal LAD and their distal LAD, and a big gap left in between. Not surprisingly, they didn't have a good outcome. I couldn't even get the IVUS down in this case. This is the positive IVUS won't go sign, never good. And the vessel was quite calcified actually as well, which is probably why there's so many problems to begin with, because it was never adequately modified. After I got an NC down, I did serial shock waving to actually modify the plaque enough for me to get imaging down. And you can see that there are some areas of undersizing and underexpansion, and this is after the use of a 2.5 shock wave. So I went on to treat with up to a 3.0 shock wave, serial NCs. I deployed stents to cover that mid-segment because it had been disrupted, and a reasonable final angiographic result. Sometimes you can't achieve absolute perfection in these scenarios. You're dealing with what was done the first time, unfortunately. Finally, this is a last, more unfortunate case. Now, this was before we had access to IVL and OPN, so keep that in mind. So this person has multi-stent ISR and refractory segments that you see here with lots of previous trials of intervention. And you see this stent and stent under expansion here. So again, here we tried high pressure NCs, sculpting balloons, intracoronary laser with contrast, no improvement whatsoever. Road ablation with 2.0 burr that basically almost got stuck, and then a 1.75 millimeter burr. Still no improvement. Here's a wire in the subintimal space, did some ballooning there for plaque modification, still no change on the IVUS. Tried to actually go subintimal and re-enter with a stingray balloon that you see here, but there was a lot of distal stent and it just proved to be not possible. So did some further NC dilatation. IVUS doesn't look a whole lot better, maybe a little tiny bit better. And this patient ultimately went on to have bypass surgery, which is the outcome ideally you want to not have happen to your patient. So lastly, just keep in mind the best treatment for all of this is to avoid it in the first place by doing an excellent index PCI. Don't forget to optimize your patient's risk factors. We are still cardiologists after all, so you want to make sure their risk factors are well managed. And if you follow an algorithmic approach to treating ISR and all of these tools that we've talked about, you can get quite a good result and outcome for your patient. Thank you.
That was great, Allison. I did have one thought. Maybe you could outlaw the 225 and 2.0 stents in your province, and that would help your cause. Faculty?
So like in your practice, I'm interested in your opinion. You know, we do quite a bit of braking, and now with drug-coated balloons, how do you think we should align those 2 tools? We're still in the process of figuring out how to acquire the financial hit of getting the drug-coated balloons, but we're thinking about how do we use that together with braking?
Yeah. So for us just to be, I think, responsible stewards of our healthcare system's finances, we have pretty good access to braking when they're not back-ordered, which they currently are. So we were going to initially, as we sort of got the value committee to get us agent at the high cost. We were going to use them for brachy failures. If someone's failed brachy, we'd use agent, assuming it's not going to be a long segment. The other thing is the balloons are limited at 30 millimeters. So at some point, if you're spending 3 balloons on one person's full metal jacket LED, which we unfortunately have too many of, and they can't be bypassed because our surgeons don't love trying to pluck stents out to drop a leam in. They will in rare cases. I think what's going to happen to all of our brachy volumes, I think it's going to go down for a little while, and then we're going to have repeat DCB failure patients that will be referred back. And Allison advocated very strongly for a good ISR prep prior to applying some anti-inflammatory effect, which is either a DCB or brachy. I think whether as agent becomes widely available, whether operators will take the deliberate approach that Allison advocated for, which is image to find the mechanism of failure, work through plaque modification to expand, to get hopefully by MLD max 80% expanded. We hope that's going to help agent be more durable. And as you also alluded to, it's really a little uncertain what constitutes a good enough result by IVUS where it's a not stent case, which I think we all have to learn in the future. But for us, we are going brachy when possible just because agent is prohibitively expensive. Darsh, you guys have a brachy program. How have you approached it?
Yeah, I think it's the same thing, Kevin. I mean, I think that from a cost perspective, so a DCB, at least at our institution, is anywhere from $5,700 to $6,500, whereas a brachy catheter is a fraction of that. So for now, the DCBs are being used when we can't do brachy. And unfortunately, like Kevin alluded to, there's a back order on brachy catheters, so we're doing a lot more DCB usage right now. Hopefully, it should be gone soon.
We're, especially in a multi-layer case, if the LED is 325, we're very comfortable taking a 40 range or peripheral balloon and using that. And we are flying through Rangers now. We can't keep them on the shelf. So we'll use the peripheral DCB off-label. The nice thing about the 018 Ranger, they're super stiff. They're meant to go into straight legs, but they will fit in a 7 French guideliner. So as you all become expert at inchworming and distal anchoring a guideliner into the artery deep, you can just de-sheath the Ranger balloon and use that. And so we use a lot of DCBs that are cheap in the current era because we don't have brachy catheters. It has to be big enough. So small prior brachy failure is an agent case for us now.
We pretty much echoed everything you guys have done. The one thing I would add, and I think you've already mentioned this, Kevin, is the OPN balloon has been a game changer for us. We've actually brought people back because we've been unsatisfied with the luminal gain that we got with conventional therapies. And once we got OPN, we realized that you could actually get quite a bit of impressive luminal gain beyond what the conventional treatments were. So we've actually brought people back. So it's a story that's still unfolding, but it's pretty exciting.
One other thing just to mention, I mean, so 10% of all PCIs done in the U.S. are due to ISR. So, and there was a recurrent theme that you saw in Allison's presentation. Most of these patients underwent PCI without intravascular imaging. So if you do it right the first time, you don't have to fix it on the back end.
I was just going to make a really quick comment just regarding the brachy versus DCB thing again. I've had access to DCB literally for all of my training and my practice. And I will say, first of all, their utility is nowhere near as good if you don't do the vessel prep. Like, they're not a fix-it tool. They're applying a drug after you've dealt with the underlying issue, and that's truly the case because I see it all the time. Like, I've seen colleagues just DEB, quote-unquote, the ISR, and they're back in a month because the underlying issue wasn't dealt with. For brachy, believe it or not, I don't have brachy in Canada, and I did a ton of it during my fellowship, and there's still patients, despite DCB, I'd love to have brachy for, and I find they're usually the ones that have full metal jackets. I hate those, by the way, even though we sometimes have to do them. But those are the ones that I find tend to end up with brachy. Despite your best efforts, they still run into problems. Or ones that you just truly, like, you do everything, you can't get a perfect expansion, and brachy may be a nice option there over DCB.
Sorry, just
welcome Evan Shlofmitz. He's going to talk to us about coronary physiology basics. Thanks, Evan.
Thanks so much. All right, so physiology, it seems something that's very basic, but this was a survey we did a couple of years ago with graduating interventional fellows, and only half of graduating interventional fellows felt comfortable in independently doing physiology. So you have the right track focusing on this now early in your training. If you really spend the time the next couple of months, using this routinely, this is something you can be very comfortable with, and it's important when you get out into practice. And one of the reasons why physiology is so critical is this was a survey done a few years ago where they called ISIS. They sent 5 angiograms to 500 experienced interventional cardiologists, asked them a very basic question: what's the percent stenosis of the lesions? And when they graded them, you see the red circle is what a core lab assessed the stenosis as, and you see every single lesion, there were answers ranging from 20% to 100%. Huge variability. It's why if your attending asks what percent is that lesion, you can make up any number you want. But we want to get away from subjective information, just like you don't want to guess it's a 225 if it's a 4-0 vessel. Rather than just eyeballing and guessing what the stenosis is, we need objective information, and that's one of the value propositions of physiology. It was mentioned earlier in the day why there's such variability is it depends what the angle that you're taking your pictures. Angiography is just 2-dimensional luminogram, so depending what angle you're taking, a lesion can, the same exact lesion could look 20% stenosis, it could look like a 60% stenosis. The other thing that's very important with physiology is where in the coronary tree the stenosis is. We're only seeing about 10% of the circulation in the epicardial vessels. Most of the circulation is beneath the surface in the microvasculature. So a proximal LAD stenosis is going to cause different amount of ischemia than a distal diagonal stenosis. So physiology is the hallmark to get objective information of what impact that stenosis has on ischemia. So basic definition, fractional flow of reserve, or FFR, is the foundation of invasive coronary physiology, and it's simply just a ratio of mean distal coronary pressure to the mean aortic pressure. And the way we do this, most of the tools have 2 sensors, a distal sensor and a proximal sensor. And if you think about a tube, and if you were to measure pressure and flow in the beginning and the end of that tube, and if it was an empty tube, it should be the same. Your FFR value or ratio is going to be 1.0. If you introduce a stenosis, there's going to be a pressure gradient. And we're simply just measuring what that gradient is across a stenosis to get an objective value on how much ischemia is occurring. And we do FFR, or fractional flow of reserve, under maximal hyperemia, which by convention most people do using adenosine. So can you advance the slide? This isn't working. Perfect. So adenosine, if you have any experience with it, there's a number of limitations, just of time it takes, a lot of side effects with patients. So there's been a big push and transition to the non-hyperemic pressure ratios, or NHPR. Every company has their own non-hyperemic pressure ratio, different acronyms, IFR, DFR, DPR. Can we go back one slide? But they're all basically the same thing. They just they use slightly different algorithms on where in the cardiac cycle they're taking their measurements so they can derive this information. But the nice thing with the non-hyperemic pressure ratios, we don't need to give adenosine. So electrical guide wires on the left is the Phillips Omni wire. IFR is a non-hyperemic pressure ratio. The main advantage with Omni wires, you can get co-registration with Sync Vision. I'll show some examples of. The software, I think, is the best in class. That's why this is my workhorse physiology tool. Abbott Pressure Wire X is another one. RFR is their non-hyperemic pressure ratio. Advantage is it's wireless for the connection, and the main advantage of Pressure Wire X is it allows you to do microvascular assessment using the Corventis system. Now, the optical pressure wires tend to be better at handling. They mimic more the workhorse wire. OpSense, which you see on the left, DPR is their non-hyperemic pressure ratio. It's nitinol-based wire. Very easy if you're using it as your workhorse to reconnect throughout the procedure without the need for re-equalization. If you want to get your hands on it, in the back of the room, they have a station. Then Boston Scientific has the Comet wire. DFR is their non-hyperemic pressure ratio, and it's a Sahi tip. Lastly, Assist has a non-wire-based measurement tool, which is their microcatheter, which is great because you can use any workhorse wire, and it's just a microcatheter, the Navis microcatheter that we use over that. So basic steps to acquire physiology. It's really important to have good hygiene because Your data that you acquire is only as good as the input. And if you have artifact, if you didn't get good basic equalization, the numbers are going to be meaningless. So it always starts with zeroing, making sure you have a good aortic pressure. Then you want to advance your guide wire to the guide tip. The sensor, it's important that you know where the sensor is on your wires. So the radio-opaque portion at the transition, that's where your sensor is. And we put that just distal to the guide catheter. You disengage the guide catheter, and that's when we're equalizing or normalizing, depending which system you're using. Then when you are equalizing, you want to make sure your introducer's disengaged. Then at that point, you advance your pressure wire. You want to make sure that sensor's distal to the lesion. At this point, you've removed the transducer. If you've taken a puff to see where you are, you want to get the contrast. Contrast is hyperemic. You want to get it out of the system. So you need to flush with saline and wait till you have a steady state. Then you take your measurements. So it starts with the PDPA. I believe you should always get a non-hyperemic pressure ratio. Depending on what the value is, if there's discordance between the rest of the clinical picture, I'll often move on and give adenosine to get an FFR. I'm using that less and less, though, in my clinical practice now because of the non-hyperemic pressure ratios. You should always, always, always do a pullback. You have to pull back the wire at some point anyway, so you want to acquire that information. I'll get into why in a moment. And then finally, a drift check to make sure that the information you have is accurate. Thresholds, really easy. The non-hyperemic pressure ratios, it's all 0.89 is ischemia. FFR, it's 0.80. But it's important to remember the numbers are just for appropriate use criteria in clinical trials. Your patient doesn't care what the cutoff is. Ischemia is a continuum, so there's, if your patient has an IFR of 0.90, that's not normal. It doesn't meet the criteria for significant lesion, but depending on what the symptoms are, it's worth getting further information. I'd often go and do intravascular imaging in those cases. Pullback. Why are pullback curves so important? It gives you the pattern of disease. So on the left, you see a diffuse pattern where there's not as much of a step up. On the right, you see a focal pattern. And when you get a steep step up like that, that's what you want to see because those are the lesions that we're going to get the best impact on change in flow with performing PCI. Diffuse disease, you're going to end up with residual ischemia. So what we're really looking for is the focal lesions, and we want to make sure we treat those with PCI. And this is just an example. 4 IFRs, exactly the same, all 0.86, but you'll see here the patterns of disease are completely different. On the left is diffuse, on the right is focal. The bottom left, you see a focal proximal lesion. On the bottom right, you see a diffuse pattern. So completely different patterns of disease. We would treat these all in very different ways with PCI, but the exact same IFR. Here's just another example where pullback information can help you. IFR is 0.6, and this is using the SyncVision software, which I mentioned, where every yellow dot correlates with a 0.01 pressure loss, and you can really see exactly where stenosis is causing ischemia, and you can also use this for your procedural planning so you can figure out what your post-PCI physiology is going to look like if you use a 15-millimeter stent versus a 38-millimeter stent. Finally, for drift check, we want that number to be between 0.97 and 1.03. If there's greater than 0.03 in drift, you want to repeat all your measurements because it's not likely accurate. And then finally, just post-PCI physiology. If you've opened the physiology wire for your indication for PCI, it doesn't cost anything additional to use it at the end of the procedure. The reason why we want to do post-PCI physiology is to check your work. What we know from defined PCI, when an operator felt they had a great result, the procedure was done, and they checked post-PCI physiology, they found a quarter of the time the patient was still ischemic. And when you looked at those patients, 80% of the time it was a focal step-up, meaning that it was something we could address just by something as simple as post-dilatation. If the ischemia was within the stent, you post-dilate, you can treat that ischemia before a patient leaves the cath lab. So very important to do post-PCI physiology. The old thinking of physiology is just for a decision of treat versus not treat as in a light switch, and there's so much more information we could gain from physiology. And contemporary physiology is really using the information from the physiology to guide the best way to treat. And just some, key points. Don't just do distal coronary spot physiology for your indication. Always do a pullback so you could really understand the character of disease. Coronary atherosclerosis is always more diffuse than the angiogram will suggest. And that's why physiology can unmask often these focal lesions, which we can improve with PCI. And post-PCI physiology will help you to check your work and see for any areas of optimizations. Thank you very much.
Thank you very much for your talk. It was fantastic. I have a question that always comes up when we talk about pressure wires. I have noticed, and I'd be curious if other members of the panel have noticed this, that pressure wire assessments of the circumflex and the diagonal are almost always, not always, but very often negative. So when I did a bit more reading about this, it seems it may relate to the amount of myocardium, pretended by the vessel. But where does that leave me in terms of what to do with the patient, assuming they're symptomatic from something in their coronaries? And is that something that you experience as well?
Absolutely, yeah. So for the exact reason you mentioned, so LADs are going to be the most commonly positive lesions, especially with the non-hyperemic pressure ratio. So LAD supplies about 2/3 of the myocardium. It's also, LAD's disease tends to be diffuse. It's why you will, if you do start doing post-PCI physiology, it becomes very frustrating in the beginning because you will never get to 1.0 if you're treating an LAD. You will never get to 1.0 because there's diffuse disease and we're treating focal segments with stents. Circumflexes will very commonly be negative ischemia, even if it's significant. So I think it's important to keep in mind, one, these are lesions, if the clinical picture doesn't make sense, if it's a real story and angiographically looks like a significant lesion and you do an IFR and it's 0.92, that's not normal, that's just doesn't meet the threshold. Those are cases, one, to give adenosine and see if there's ischemia with adenosine, and two, intravascular imaging. It's why I'm an imager first. Physiology is important, but always image first. If there's a reason, once you've anticoagulated a patient and dropped a wire, if you're not, so the evidence is that you can defer PCI if you have a negative value, but if your patient has real symptoms and a reason to have a guide wire down their coronary, I would always do intravascular imaging before I conclude the procedure.
Evan, quick question for you. Are there scenarios where you'll go directly to FFR and not use the non-hyperemic indices?
Yes, if the research trial protocol mandates it. That's the only time in my practice. I personally don't do FFR unless if the non-hyperemic pressure ratio is negative and the clinical picture suggests that this is likely an ischemic lesion. Now, if the non-hyperemic pressure ratio is 0.98, and it was atypical symptoms, and I'm doing this to document there's no ischemia because I know the referring is going to challenge why I didn't do PCI, and that was the only reason I'm doing the physiology, I don't go on to FFR. But if it's discordant with the clinical picture, I go, that's really the only time in my practice that I'm using FFR, and there just wasn't time to go over this, but realistically in practice, when you suspect this is going to be a negative physiology case, nowadays, angio-FFR systems are available, and then you don't need heparinization, you don't need to wire. So I think that's another tool that's very important in your clinical practice, and hopefully you guys will get exposure in clinical practice, things like CathWorks and angio-based FFR.
I was also just going to say the left main, the non-hyperemic indices have not been validated in the left main. So if I'm going to do an assessment of the left main, I do it with FFR, but that's the only place. And
he'll likely correlate with IVUS as well, because there's a lot of benefits. So that's the one place. Physiology is your light switch, your gatekeeper for indication for PCI. Imaging guides how to do PCI, but in the left main, actually, intravascular imaging, particularly IVUS, is indicated for your indications.
A couple of comments. Great presentation. I have a couple of comments and something back to you. One is the Yeah, I think it's important to add that there's like a 20% or so discordance between non-hyperemic pressure ratios and FFR. So I think this is an area of debate, but I can tell you that in our practice, we have actually seen a dramatic increase in use of FFR again, because we have now FFR CT, we have FFR angio, and therefore we want to compare apples to apples, not apples to oranges. So I would say that a common pitfall that we see is that, let's say somebody has an abnormal FFR CT, somebody comes, does a non-hyperemic pressure ratio, they say, see, this CT was bogus. But then when you do hyperemia, they match pretty good. So again, we've been using it mostly to compare apples to apples and other scenarios like left main. And something, back to you, is that, I don't know, we've discussed it, but something that has changed my practice, and I know you guys advocated a lot, is body wires. I've been a huge fan. I used to use it a little bit, then more, and now I feel like I use it all the time. So maybe you want to add to that, because I know you guys are big proponents of that too.
Yeah, so I learned this basically from one of my partners, Alan Jeremias. This is something that he's big on. All physiology I do with a buddy wire. So I use a separate workhorse wire, and the reason why, it allows you to get high quality results. So one, when you're normalizing, when you're checking for drift, you want to disengage the guide. And if you have access, you're going to see that as a fellow, you're going to be excited. You got good guide catheter engagement. The last thing you want to do is completely disengage that and have issues getting back in. So that's one thing. You're going to be much more comfortable if you have a rail, if you have a workhorse wire to work over for your disengagement. Two, you're going to be more comfortable doing a pullback if you don't have to rewire and worry about crossing the lesion. So what happens oftentimes is someone does an FFR, does a non-hyperemic pressure ratio, it's positive, so they're moving on to PCI. The last thing they want to do is take that wire out. So if you have a buddy wire down, if you have a workhorse wire that's down across the lesion, you don't mind doing a pullback, which will let you see the character of disease. But importantly, it's going to allow you to do a drift check. And if you don't do a drift check, you could be making your decisions on a completely false reading. Now, the majority of the time you don't have drift, but even with modern wires, you see drift as often as 17%, depending on the wire. So particularly with electric wires, you could get up to 17% drift. So if you're making a decision, particularly around the cut points, if an FFR 0.79, 0.4 of drift will actually change it from a positive to negative lesion. So you really want to be doing that drift check. You're going to do it every time if you have a workhorse wire. So I think that's very important. There's a lot of debate among the physiology purists of does that impact the reading. 0.01 is the impact on the reading. In our lab, we strongly feel that if a 0.14 wire makes you ischemic, you probably deserve revascularization.
Thanks, Evan. It's awesome.
Thanks.
I think we're going to move on to our second to last presentation. Luis, who's an OCT expert that spent a bunch of time in a core lab before he became an attending and a fellow in attending, is going to talk to us about the basics of intracoronary imaging, which has been an explosive field over the past couple of years, I think, in some parts of the work that your group's done from research standpoint. So cheers.
Thanks so much, Kevin. Thank you so much, the organizing committee, for having me here today. Thank you so much, Manus, and Mary, and Sebastian, and Paul, for the opportunity. So for the next 8 minutes, we're going to talk a little bit about intravascular imaging. There's a very vast topic, so I hope that we can go over the main aspects. So I want to talk with you about the intravascular imaging main modalities, when to perform intravascular imaging, and lastly, the main evidence and the clinical trials showing the results of superiority comparing to angiography. So let's talk about the main modalities. So the evolution of the imaging is, as everybody knows, has been very impressive from early 50s now. So the tendency is that at some point we're going to merge the anatomy assessment with the physiology assessment. Physiology to decide if you're going to treat it or not, and the anatomy to see how you're going to treat the vessel, right? So at some point, we think that both are going to merge. We already have this technology. We just have to spread this technology to have both assessments at the same time. So here we can see the main modalities that we use, the IVUS and the OCT. For those who doesn't know, the left one is the IVUS, the right one is the OCT, and the right one, the OCT, has much more definition, much more resolution than the left one. So now we have the high definition IVUS that we've been using with more details, so we can have more resolution. But OCT has around 10 times more resolution than IVUS. The advantage of IVUS over OCT is the penetration. So when you have large vessels, you can use IVUS so that you can see beautifully all the layers of the vessel. If you're using OCT, sometimes you can miss some part of the vessel. So for large vessels, we prefer to use IVUS. But the downside of the OCT is that you need contrast injection. So to get a good imaging for OCT, you need like a continuous injection of contrast. So if the patient has a kidney disease or has some issues, you have to think if you really can do this constant injection. You usually need at least 14 cc's of contrast to get an adequate imaging with OCT. Here you can see that mostly the OCT has more, as we said, has more, you can see more details. It's like a microscopic cut of the vessel, but sometimes you don't need that much information. So I would say that you can use either IVUS or OCT for most of the cases. Some situations you would prefer IVUS, some situations you would use OCT, but for most of the cases, 90% of the cases, I would say that you can choose either one or the other technology. For some examples here, so to the left, you can see the calcification. You see much better calcification through OCT than through IVUS, right? For IVUS, you see a shadow, and for OCT, you can even draw the calcification, right? To the right side of the slide, you can see like an edge dissection, so you can see much more details for edge dissection with OCT than for IVUS. For thrombus, also OCT is better. So for thrombus, the sensitivity of the OCT is almost 100%. As for compared to the IVUS, that's around 33%. So it's much better. If you're doing a case with ACS, sometimes OCT is preferred instead of IVUS. So here in this slide, you can see that most of the times you can use either technology, but for some specific situations, such as big vessels, left main lesions, and for patients, when you want to minimize the contrast utilization, you should prefer IVUS. So in a nutshell, which modality should you use? You should use the one that is available for you. I work in 3 hospitals. One of them just have IVUS, and the other 2, they have both. So in the one that I just have IVUS, I just use IVUS for all of my cases, and for the other hospital, I can decide which one I'm going to use, right? I would suggest you to have a lot of familiarity with one modality of those 2. Once you get expertise, you can see much more details, and you can approach the lesions accordingly. So when to perform intravascular imaging? So in my practice, I always use, almost 100% of the cases I use IVUS, I use intravascular imaging. And I think that the state of the art to do a proper PCI is to use imaging for all of our cases, right? You have better procedural outcomes, you have better clinical outcomes. Some places like Japan, they have over 95% procedures using intravascular imaging, and the decision-making can be changed in over 80% of the cases, as we're going to show some pivotal research from Dr. Kevin Croce here. To do pre or post PCI imaging, so the answer is to do both. So we have to address the lesion before and after. So before to know how we're going to treat the lesion, and after to see the result, if it's adequate, or if we should do some kind of additional assessment. So it's very important to follow these steps: the assessment, the imaging, and the reaction. So this is a Light Lab initiative conducted by Dr. Croce. He was the PI of this trial that was presented in EuroPCR 2020 and published 2 years ago in this cardiovascular circulation cardiovascular imaging. So here you can see that in almost 88% of the times you had some change in your reaction when you did intravascular imaging. So most of the time it was before, 83% of the times pre-intervention, and 31% of the time is post-intervention. So in a nutshell, if you do intravascular imaging up to 8 times out of 10 times, you're going to change something. You're going to put a longer stent, you're going to put a bigger stent, you're going to change your practice. So it's very important to do intravascular imaging for your cases, right? Because of that, Dr. Croce and his team have developed this MLD Max protocol. It's very easy to memorize so that you can assess the morphology, the length, and the diameter of the vessel before you do the procedure, and after you do the intervention, after you stent, after you do the treatment, you can do an assessment for the dissection, for the apposition, and for the expansion of the stent. Okay, so this is a picture of how you can do some co-registration. So on top of getting the image, you can also co-registrate the angiography so that you can know exactly where to put the stent, where you're going to treat the lesion. Right? I'm running out of time here, so I'm going to pass some of the slides. So here you can see some examples. For example, if you have a fibrous or a lipid plaque, it's very easy to expand the stent. But in the middle, if you have a very calcified lesion, sometimes you have an under-expansion. So you have to go there and you have to do some other types of post-dilation, shockwave, or other types of post-dilation so that you can have an adequate expansion of the stent. So here's an example of a very important assessment of in-stent restenosis. So sometimes when you have restenosis, you must understand what's going on, as Dr. Hall showed brilliantly. So if, for example, here, if you have a neointimal hyperplasia, if you know what's going on, you can address that. So in this situation, we did laser, and you can see the size of the final size of the vessel, very impressive. How much lumen did you gain just based on the information that the patient had no intimal hyperplasia. If this patient, for example, had just under expansion of the stent, you could go there and just with a balloon expand the stent, period. Nothing else to be done. So it's very important to do an imaging prior to these cases, right? And just to finalize, I just want to tell you that last year we had a bunch of great new articles published in great journals. And now we have a robust information, robust data showing that intravascular imaging together, either IVUS or OCT, can reduce cardiac death, can reduce myocardial infarct, and can reduce target lesion revascularization, and even stent thrombosis. So if you compare intravascular imaging with angiography, you can have great procedural and clinical outcomes. To finalize the presentation, the guidelines, and the European and the American guidelines, they focus that intravascular imaging should be used especially for left main. It's almost mandatory to use for left main, as it was discussed here before. And when you're addressing like in-stent restenosis or patients with high complexity procedures, you should do the imaging so that you can have better results. So take-home messages: intravascular imaging changed the decision-making process for treating injuries in more than 80% of the cases. Compared to angiography, the use of intravascular imaging reduced the risk of death, infarct, revascularization, and MACE. For high-risk procedures, it's almost mandatory to use intravascular imaging to have better outcomes. And lastly, the current studies comparing OCT or IVUS against angiography have clarified that they have great benefits in procedural outcomes and clinical outcomes when you use intravascular imaging. Thank you so much.
That's great, Luis. Thank you. Darsh, you image all your cases. What's up with the guidelines?
Yeah, so I mean, clearly there needs to be an issue, change in the guidelines. The reason why the authors have stated that the guidelines aren't class 1 is for 2 reasons. One, there was a concern for medical legal reasons, but the second is that a lot of the data was in a non-Western population, mainly from Asia. And so the thought is to replicate it, but we are now have an abundance of data. If you look at meta-analyses, and the most recently, Greg Stone published a meta-analysis in The Lancet that looked at over 22 studies. And there's an overwhelming mortality benefit, overwhelming MACE benefit. So, I actually think if someone isn't using intravascular imaging, you have to ask why. I think it should become the standard of care.
For the faculty members, do your cath labs track imaging use as a quality metric at this point? Just raise your hands or go down the line. I think, Louis? We follow it at M&M every month with our usual, like, we did so many cases, we did so many radials, we did so many imaging percentages. So it's something we look at as a quality metric to try to get people on the page where it's done routinely.
We don't identify who are the physicians who are doing and who are not doing, but yes, we have this.
We don't either. We get our own de-identified information. So we know our partners are doing it at 90, and if you're at 20, it tends to guilt people into it, but it's not shared who they are. It's actually a nice way to understand how to impact change, right? So quarterly we get like, I'm the most expensive operator on a per cost basis. So I'm always mindful of, do I need that guideliner or microcatheter to cross? But, so it's a way to potentially gently influence group behavior without being confrontational. So we look at it both ways. We look at it monthly based on a percentage, and we look at individually in a de-identified way.
I'll say one thing. So at my institution, I was at our former institution and then moved to my institution. The intravascular imaging usage was not nearly where it is now. Now we're north of 95%. And the reason for that change was really driven by the fellows. Basically, the low imaging operators got shamed and guilted by the fellows. And so they had to sort of become facile. So if your faculty members aren't using intravascular imaging, at least say, why don't we use it so that I can become comfortable with it, and over time you can guilt them into doing the right thing.
And the best part is you can teach them how to use it, because you guys, as I said, are bees and will pollinate from one operator to another. That's great. Other comments from the faculty?
Yeah, I just have one question. What's the opinion on doing saline injections in OCT? You mentioned that in patients with kidney failure, you rather use IVUS, but you could theoretically use saline injections for OCT. Do you do it? Is it common practice, or you don't really?
That's a great question. You can use saline to do the pullback. The quality sometimes, when I do saline, it's not as good as when you do contrast. So sometimes instead of doing many pullbacks, if you don't have a good quality of pullback, you cannot use that information, right? So sometimes when the patient has kidney disease, for me to avoid to have crappy images, I go straight to IVUS.
Yeah, Evan's colleagues and himself have sort of spearheaded this. A lot of it, you can't expect to get the full 74 millimeters of pullback you get on the usual OCT, and it's much easier with a 7 French guide. It's much easier on the right than it is the left, but with a little bit of coaching and a 7 French system, you can get reasonable images repetitively. You just can't get long imaging. It has to be limited to about 30 or 40 cc's, and it typically takes about 20 cc injection at minimum. Other thoughts, Evan?
Well, Evan, comes something that I want to add is just practical for the fellows is NURD, non-uniform rotational distortion. It can happen, particularly with OCT, so use soft wires, keep the two-way open. So familiarize also with the artifacts of each modality.
Yeah, I agree with Kevin's comments. Saline, you get great pictures, but very short pullbacks. There are 2 newer intravascular imaging catheters that use OCT with a 1-second pullback. So with those, it's just a little easier to get a good imaging run with saline. Just a thing to add about reporting, I think with quality metrics for the intravascular imaging use, one thing to be aware of if you're going to practice in the state of Michigan, Michigan has made it a quality metric, intravascular imaging use by hospital and doctor. So this has been actually led by insurance companies in Michigan because they realize the impact of intravascular imaging. So hopefully over the next several years, this is going to roll out to other states. And then the other thing with using intravascular imaging, if you get very comfortable with image interpretation, your older attendings who aren't comfortable with imaging, they're actually going to want you in every procedure. So it's a way to get access to more cases, which you want. If they know that you can interpret the images, all of a sudden you're going to find some of those private attendings who never like fellows in their room, they're going to be asking for you for every case. So it's a great way to get cases as a fellow.
Thanks.
Thank you very much. I think we'll move on to our final speaker. We have Dr. Brilakis to talk to us about how to manage complications, use of non-technical skills.
Thank you again. Thanks so much. A great session. Before we start, just to make sure we acknowledge our sponsors, Abbott, Asahi, Boston Scientific, Haemonetics. Thank you so much for supporting the course. Great learning for everyone. Also, a couple final thoughts about after the course, we'll have a little hands-on on every session for 10 minutes each. So if your last name starts from A to D, you'll be in the first group at Abbott. E to K will be the second group, which will be Asahi. L to P will be the third one, which is Haemonetics, and then R to Z will be at the Boston Scientific and will rotate. So I will just discuss a little bit about technique. We talk about technique all the time, but it's much more than that. And these are some things that are not necessarily shown on the book about the algorithm for putting a perforation covered stent or the algorithm for taking care of dissections, but some skills that you may find useful to prevent burnout and feel better down the line, because as you'll see, burnout is becoming more and more. So we'll start with both before the complication, but then also during the complication and after the complication. And these are the skills that actually can help you get through this in a more successful way. So in terms of preparation, how do you prepare for a complication? And being curious is actually one of the simplest things. What happened in the lab? What did you do for that case? Talking to people, being curious and learning is simple, but this is what it is all about. Being curious, you're going to be exposed to more things. It's not always in the books. Some of the best tips and tricks came out of informal conversations in meetings like this or over the phone with other people. There are many books, there are podcasts, there's YouTube, there's many other avenues. And there are other also ways to prepare which have to do beyond knowledge. So the knowledge is important and makes you much more comfortable, but there are more than that. And one of them is the self-denial, the ability to tolerate pain. Now, you're going to say that being an interventional cardiologist, you're expert at this, depending on your hospital at various degrees, but it goes much more than that. And I think part of this, the problem is that you stop appreciating things. So a case goes well, you take whatever, you expect it to go well. But when it doesn't, then all of a sudden it's a big deal. I mean, why didn't it go well? What it's supposed to do? So preparing for this by sort of failing or denying ourselves some things can really harden us against misfortune, such as complication or other things that can happen down the line. Now, this may be a little extreme, but being able to function if you don't have lunch or if you didn't have to go to the toilet, that actually can be useful in those complicated cases where you're stuck for 7-8 hours in the case. Also helps the waistline. And also, there are other things, like simple things, like the wires. We talked about the wires before, right? You can use a BMW in every case, which is great, but if you use 10 wires, then guess what? You may find the one in this particular case that will take the 3 bends and get you through that lesion. And then also start doing more complex cases. If you avoid every complex case, then you're going to be less likely to do things down the line. Asking for help actually is uncomfortable. It's not always easy to say, look, I have a problem, I need some help, can you please come and help me? And then sharing the complications is also not easy because it's often difficult to discuss about the things that have happened before. Now, another way to think about it is having a good rest. Now, you would say you're STEMI call, how do you expect him to have good rest? Well, the day after, don't go to bed at midnight, just try to catch up later on. You're much more likely to be balanced and function better if you're not sleep deprived. There's a technique called negative visualization, which means think what can go, how much worse things could have been. Like, for example, you had a perforation, well, it could have been worse. You could have a perforation to go to bypass, or perforation that the patient might have died. Okay? Even if that happens, at least you're alive. So there's always something positive about everything that happens. Actually, I was in a visible heart lab, and you could have 200% complication rate. They was doing this circulation from the parent to the child. So actually, you can have in an operation 200%. So it can always be worse than what you're used now. And also, remember, the sun will come up the next day. Even if you have a complication, guess what? The sun will still come up. Now, it can happen at any stage, even before you do this, during the procedure, thinking what can go wrong. Actually, that may sound morbid, but actually helps you find the complications, soon diagnose them, and go. Or then, as I say, afterwards, it could have been much, much worse. Knowing what can go wrong, actually, there are finite things that can go wrong. I'm sure I say that, and tomorrow I'm going to have a complication that's completely out of the list. But For the most part, it's you either close the vessel or you perforate the vessel or you lose something, and that can translate to MI or tamponade or arrhythmias or access complications, thromboembolic, radiation, contrast. That's it. All right, there's so many things you can do bad in a patient. Now, we did have a patient time that the table broke, the patient fell. But anyway, this is not here, but anyway, most of them will be there. Now, you could say, when you make you anxious to actually have all this, well, again, the point is not to get anxious, but to consider everything that can happen and then be grateful for when things actually go well, because we get conditioned to expect things to go perfect at all the time. This is exercise to do, apart from interventions or not, every day I'm grateful for 1, 2, 3, 4, 5. The more things you feel you're grateful for, the better you're going to feel down the line. Now, the next step is during the case to find the problem early. And we all have music in the cath lab, we have jokes with the teams, we're talking about the game. But the reality is, it's hard to multitask. And in the cath lab, if you do multitasking, chances are you may miss something or realize it later on. There are a million things to look for. That can be contested into 12 things. The most important is the EKG and the pressure. If you have this habit of looking at this before and after every case, you're more likely to detect something very quickly before things go south. At the same time, if the patient stops responding, it could be sedation, it could be something else, but this is the trick that they were doing in fellowship. Dr. Nishimura would turn off the pressure and wait for us to figure out that it's turned off. And you'd be amazed how long it took. It took from 5 minutes and gradually declining. But this is a huge skill to have, and sometimes you forget it even at this stage. Now, when this happens, what do? The cath lab can get an animated place. It can be a little stormy in the cath lab. Everyone is running around. You call for anesthesia to intubate. 10 people are coming in, the nurses, the techs, the code team. So it can be a little crazy. So you want to be the, you actually want to be the person who is stable. You want to be a stable person into the eye of the storm. And the other thing you want to do is to go quickly from the stages of loss, from denial, anger, bargaining to acceptance. It didn't happen. There's no way there's a problem. I mean, how can this happen? I mean, I'm the best. Bargaining, I'll never do it again. You know, please let me get through this one time. Then you get depressed. It's over. I'll lose my job. I'll have to go to peer review. Have to explain to everyone. I'll show it at the meeting, see what happens. But then accept, okay, this is the problem. Do something about it. I always like to show this picture. I went to Zion Park a few years ago. There's this high called Angel's Landing. Many people have died there. You can see why. So when you look at this, I mean, that's exactly what you feel. You're going to die because you look at it and you literally, I mean, I haven't felt this before, actually. You actually freeze. I didn't want to move. I want to just hold on the chain and do nothing. And then they explained to me, if I look down, this is what's going to happen. What you have to do is turn around, look on the chain, and then go down. And that worked. So when this problem happens, what you have to do is not think about the worst thing, but okay, step by step, 1, 2, 3, 4, that helps you get through this problem. And don't forget in everything that you don't control everything. Actually, the outcome, I don't know if you think about this, but every time we do a case, it's an experiment, whether you believe it or not. You never know the outcome. I mean, you think it's going to be fine, 99% is going to be fine, but 5%, 1%, you're going to have a major problem, and you don't necessarily control it. I mean, you control what you do, your actions, your thoughts, but actually what happens in the case is only under your partial control. And realizing that there are things that can happen regardless of you, it's critical to actually manage it better and get the best possible outcome. Also, another technique from the Stoics is the reframing. You know, something go bad. So one interpretation is that I'm a bad person, we're doomed to failure, the patient is going to die, or you can think of it as, hey, you know, this is a great opportunity. I saw this case at CVI. Guess what? Now I have the opportunity to practice it myself and show my great skill. Now, it's a little hard to do this when the patient is getting CPR, but again, it can really help you get through this. There is this curve that once you start getting nervous, actually performance increases. But if you get too nervous, then performance starts going down again. So keeping calm is critical. You want to be in control, not a good time to start swearing. And then you want to be actually still functioning high, but also being open to suggestions. It's not your way only. You may miss something. It's good to get the input from everyone in the room. So trying to keep calm is critical during those cases. And if you know the algorithms before, it helps. If it doesn't, the good news are you're very likely to remember it much better the next time. So there's always a positive, a silver lining in everything that happens. Now, the aftermath. This happened. Obviously, you take care of the patient. But then these are the emotions that often come up. One is guilt. And then there is shame. And Brené Brown talks about vulnerability, great books to read about, but guilt means that you feel that you did something really wrong. And then shame means that you feel that you are inferior and you are flawed and unworthy of love and belonging. And this is actually exactly what feels after a major complication, especially if the patient dies. You get over here. I mean, you get both of them, but especially this one. And the simplest solution is, first of all, time cures a lot of things, but also talk to people that you trust, not the peer review committee. You're going to call the people that you have. And actually, this is one of the goals of the meeting, like being here is, I mean, knowledge is one part, but the second key part is the connection and having a few people that, you can call and you can explain what happened. And I call people when bad things happen to me, and people call me as well. And I think this is one of the great ways to go there. Dr. Banerjee, his cell phone will come up. You can call him 24/7, 365. And then what you can do about it, the best part, actually the best way to feel good about a complication is to understand what you can do better in the future. There are many, many complications that happen in the future. There's this book that says, the goal is to be useful. This complication, it's bad, but this can be useful to you and to other people down the line. So understand what happened, what did you do, take care of the family. What happened, happened. There's no point to just keep on thinking about it. Things happened. You cannot change it anymore, but you can have a positive impact in the future. And whatever happened in one case is the before for the next case, and so on and so forth. You're going to spend the time with the family, explain what happened. You're going to spend time with the staff. That debriefing you mentioned before, that's the debriefing that is the best way to go. Talk to the staff, the nurses, the techs, the fellows. Everyone gets a little traumatized in this case. It's good to discuss about this, and everyone feels better after all that. And then, last but not least, realize that, I think Bill Lombardi says all the time, you're a good person, you try your best, doesn't always work, and this is not the reason to become broken, but there is ways to go over it. Complications is one of the reasons that people feel burned out, and the goal is over time that these big swings for confidence to desperation to become narrower and narrower, so you function at a higher level at all given times. This is a work in progress. It will never be 100%, but with time it gets better and better. So I think I'm going to stop here. I think it's been late, but the bottom line is complications are not always a bad thing. They can happen. You can quite often bail out of them. I get surprised myself how often I get something bad and the patient turns out fine in the end. But the bottom line is to prevent them is the best way. When it happens, get the best response, stay calm, communicate with the team, and at the end, communicate with everyone else and make sure you make the most out of it. Thank you so much.
Manos, I'll ask you something. Great presentation. How do you, because these are great individual techniques, how do you engage the team? Because you're trying to do this. Let's say you say this is great, I'm going to apply it, but you have a general fellow that is not interested in the cath lab. The nurse is buying something in Amazon. There's somebody in the back. How do you engage the team?
I think, what was it, Gandhi, that a mother came to him and said, my child eats sweets, tell him not to. And Gandhi says, okay, but not quite yet. So says nothing to the kid. So then the Gandhi comes again back like 6 months later and tells the kid, don't eat sweets. And the mother asks Gandhi, okay, why didn't you tell him 6 months ago and you had me come back 6 months later? And he says, because at the time I was eating sweets myself. All right, so if you're on your cell phone, and it's hard, you shouldn't ask from someone else something if you don't do it yourself. So, I hate to admit that, many of us, sometimes we're not necessarily 100% engaged, 24/7. And I think the best way to do this is to actually be the example, put your cell phone on silent on the table, and being there engaged and interacting. I think it's the best technique. If you are engaged more, I think the whole team gets engaged. Now, is it 100%? No, there are going to be some people that are, maybe less engaged, but I think the best you can do is give the best example and then see how it goes.
I find sometimes, too, if you can, as you mentioned, obviously, congratulate the team on their efforts and after a complication. And also, if there are particular learning points that you've noticed, when the timing is right, which is important because you don't want to throw it out there at the wrong time, but sometimes say, this was great, these are the things we did well. What we'll do is we'll take some time to think about this and circle back and see if there's anything we can work on as a team next time. And sometimes people are really interested in that, especially if the patient has had a poor outcome or just barely made it through. They want to know how they can do better next time. And I've had some good chats with staff in my lab after those kinds of situations. They've gone really well.
As much as it sucks when these things are happening, we do, I often look at it like as a crisis of conscience of whether I should have been the environmental consultant, which was my other job choice other than medical school. But we tend to be really deliberate. Like we floor restore every part of the case while stuff is happening, because as much as the self-pity's there that God, this is awful, you figure you're at least going to learn something from it. And a lot of the best content that Manos will bring to some of the complication courses that we have them to, and colleagues do, is like just having the wherewithal, like, this is terrible, but we're going to at least document what's happening here. It also, legally, it can help, because you actually have a case series, from a perforation to next thing, the wire's out. You don't know what happened in the case. It does leave you a little bit uncovered, too. And so oftentimes you know what to do because you've learned the algorithms, and you can actually look at it as that's the positive, is we're just going to kind of work through the problem and sort of take it step by step and try to be clear showing what happened during it, which not everybody's willing to do. It takes a little bit of time and probably a little bit of experience, but it can be really helpful just in terms of review later. The meeting that we're both part of, the faculty has sort of come up with the hashtag #FluoroStoreEverything, because it can be going to hell, but there's usually a pretty good categorization of what's happening through the whole case, which has been helpful from teaching. And if it goes well, then you've got like a nice catalog to help other colleagues, to the point that there is a positive that comes out of these. You'll learn from it either way.
I totally echo what you said, Kevin. We actually fluorosave everything, and we actually we have an Excel spreadsheet with keywords on it so that anybody that's doing a conference can quickly pull up films, and everything's fluorostored so that they can use that during the conference when it's appropriate. So I think that that's huge, and I encourage everybody to do it. It'll certainly help you to come up with talks when you're asked to give a talk.
If I can add, I think, and this goes again to the fellows and junior faculty and whatnot. I think it's important to empower the team. I think all of us have been in labs that there's a lot of people, but sometimes you feel alone. And I think it's important that you engage the whole team, like the nurses, the techs, the fellows, everybody. Like you see something, say something, talk to them through the steps of what you're doing in the case, and they can be an proactive member of the case. Like, hey, that wire is in the side branch, or did you see that leak there or something? So in any case, I think it's just an important part of complication management to engage the team.
The other thing is, during your fellowship, you're going to have some terrible days where you're going to be emotionally and physically spent. I think it's important for you to have hobbies that you still continue to nurture outside of the cath lab and rely on them regularly. For me, at least when I was a fellow, it was working out. And I'd go to the gym at like 10 p.m. at night just because that was the way I would deal with my stress. So I would have some sort of activities that you can kind of default to sort of let the pain of the day roll off for you.
Do you want to wrap us up, Manos?
All right, perfect. So if anyone has something to tell to us, please feel free. It will be out there. But actually, jokes apart, I had some complications and wrote them up actually as a paper. Peer review committee came back. I sent them the paper. They never came back to me. So there's actually a self-defense component of writing down and documenting exactly as what you're saying, or fluor storing and having everything there. So again, thank you so much. Lots of learning today. To just summarize again, A to D will start in the first station, E to K, that's the last initial, right? And then in the second one, L to P in the third, and R to Z on the fourth. Thank you so much, and looking forward for a great meeting.